Thank you for being patient. Sorry I didn't get to go around and meet everyone. I'm going to hope to do that before the end of the day, but we're so pleased to have so many of you here to talk about lung cancer today, a critically important topic, as we all know. We're preaching to the choir today, but we all learn together, so that's what's so important. My name is Jeff Seeler. I'm the CEO of the American Lung Association of the Northeast, and on behalf of everyone in our organization, we want to welcome you, and again, we thank you for taking time out of everyone's busy schedules to be here today for our Lung Cancer Summit, New Hope for Persons and Families Fighting Lung Cancer. I just do want to say one thing about the program. There was mention of prostrate cancer in the first page, and we just want you to know, even though it's not part of the lungs, we know it's a mistake. So that was a typo. It is a word, so spell check didn't pick it up, so we apologize for that. But we didn't want you to go through the program thinking we didn't know. So again, we're pleased to have such a prestigious group here in this room gathered to step up to the challenge of lung cancer, which, as we all know, again, the leading cancer killer in the United States. For decades, the American Lung Association has been fighting lung cancer. We've been funding research and providing educational programs for all populations, including those who have never smoked. We've made a real difference with our smoking cessation programs and tobacco control efforts, strengthening laws and policies that protect everyone from secondhand smoke and prevent young people from starting smoking. But we know that tobacco control is only part of the story. Tackling the huge challenge of lung cancer takes a multi-pronged approach, including secondary prevention strategies. Lung cancer is often diagnosed far too late, and the 5-year survival rate is lower than for many other cancers. Screening of high-risk populations now holds the promise of early detection and provides a historic opportunity to save thousands of lives each year. And Dr. Andrea McKee, who is from the Boston area, is on our nationwide lung cancer medical advisory panel, calls screening the new weapon in the fight against lung cancer, and I think that's a really good description of it. In addition, with recent advances in treatment, there is hope. New resources for navigating the journey from diagnosis through treatment and survival, understanding a team approach to care which utilizes supportive oncology, and learning about new treatments and medications all provide hope for those diagnosed to fight and survive. It's clear that now is the time for us to work together to ensure that people in our communities receive the lung screening they deserve and also the information and education necessary to chart a course for hope and survival, which is why we're here today. Again, we're fortunate to have all of you in the room. We're fortunate to have an amazing lineup of speakers. Thank you all for taking time again to join us. And a special thank you to all of our speakers and panelists for those of you who are in the room. I'd also like to recognize in particular members of our planning committee. It took many months of putting this together and a lot of phone calls, and we're very grateful to all of you. I'd like to read those individuals off. If you're in the room, if you could just wave. Dr. Neil Schachter, pulmonologist from Mount Sinai Medical Center and on the American Lung Association of the Northeast Board, also a former board member at the national level for many years. Andrea Barandi-Kitts, retired aerospace engineer, lung cancer awareness advocate, Masters of Public Health student, and someone who lost her husband to lung cancer in April of 2013. Denise Hogan on our staff here of the Lung Association, and coordinator of the Rockland County Power Against Tobacco, and also a lung cancer survivor. Batya Rexon, licensed clinical social worker and oncology social worker from Mount Sinai Medical Center. Tyrone Thaddeus Brown, PhD, interdisciplinary program manager, Institute for Continuing Education of 1199 SEIU Training and Employment Funds, and you'll be hearing from Tyrone later. Sarah Lawrence, Director, Institute for Continuing Education, 1199 SEIU, League Training and Upgrading Fund, sorry, there was no space there. They're testing me on these, I think. Is Sarah here? Yes. Since I butchered your role, I want to make sure we know you're here, Sarah. Thank you. And Peg Collins, who is Vice President of Health Education and Research from the American Lung Association of the Northeast. Michelle Tofano, Director of Health Education from the American Lung Association. All of our staff's in the back. Carmen Torres, Program Data Manager from the American Lung Association, and our own Liz D'Imperio, who is a respiratory therapist and Director of Health Education for the Lung Association based here in New York City. So again, can we have a round of applause for that group that put this together today? You can tell it took many hands to do this. Before we move into the program, we want to take a few moments to share a campaign, an initiative that the Lung Association has launched called Lung Force. It is a national movement led by the Lung Association to fight for women's lung health and most urgently to fight lung cancer. Something that a lot of people say is, well, what about men? And that's a very valid thought, and this is about lung cancer in men and women. The approach and outreach to our public is designed for women, because we know women are powerful, and they're going to bring men along for this issue. So just want to point that out. We're not ignoring lung cancer in men. Lung Force arose from the sobering statistics around lung cancer, specifically the lack of awareness of its impact on women, and how as a nation we've created false lines between who gets it and who doesn't. We have downplayed it in comparison to other leading killers. That's an understatement, isn't it? And somehow we've lost traction in our fight against it, all things that the Lung Association wants to begin to change. This lack of awareness was discovered when we launched our Women's Lung Health Barometer, which was a survey of 1,000 women across the country to test and survey their knowledge and perceptions about lung cancer. So let's take a look at that.
When women were asked which cancers were the most dangerous for them, their answers were not that surprising. Yet only 1% of women said that the #1 cancer killer of women in the U.S. was top of mind. And which cancer was that? Lung cancer. Lung cancer kills almost twice as many women as any other cancer. Did you know less than half of women diagnosed with lung cancer will be alive a year after diagnosis? That's just one more holiday season, one more summer at the beach. The thing is, most women didn't know lung cancer is the #1 cancer killer of women either. In fact, only 1 out of 5 were aware. But after learning the truth about lung cancer, one thing most women agreed on is not enough is being done to raise awareness about the disease. The truth is, anyone can get lung cancer. Although smoking is a leading cause of lung cancer, it's not the only cause. Factors including exposure to radon and air pollution can also play a role, along with genetics. In 2014, an estimated 72,330 women will die from lung cancer. That's more than the average capacity of a U.S. football stadium. Better prevention, early detection, and more personalized medicine will save more lives from lung cancer. Research, advocacy, education, and awareness will get us there. Although women believe everyone has a role to play, 80% believe it's very important for policymakers to take action. You can help today. Raise your voice for change. Share what you know with others, and join the fight against lung cancer in women at lungforce.org.
These are sobering statistics. We know, again, many of you may be aware of these statistics in the room, but these are statistics that we need to make known to the general public, and we need to build the awareness and the action about lung cancer, and it's imperative that we change them. So we've given Lung Force 3 priorities. First, make lung cancer a cause that people care about and act on. Second, to educate and empower patients and healthcare providers. And third, to raise critical funds for lung cancer research. We believe lung health is a human right. We must raise our voices to make a change and fight for every woman's right to breathe. Lung Force would not be possible without the support of our sponsors, especially our national presenting sponsor, CVS Caremark. We all know that CVS is removing tobacco from its stores as of October 1st, so we always like to give them a round of applause anytime we can. That was a very courageous move by CVS. Through Lung Force, we will make lung cancer a cause that people care about and act on. We will support patients and empower healthcare providers, and we will drive policy change and raise critical funds for life-saving research to reverse the course of this devastating disease. Lung Force celebrates the power of women's voices, using music and voice as a symbol of what women can achieve with healthy, forceful lungs. And we're excited to share that 3 celebrities who have achieved success with the power of their voices have joined us as spokespeople in the Lung Force movement. Our celebrity voices include Kelly Pickler, who is an American country artist who you may recognize from American Idol. Kelly's grandmother, who raised her, died of lung cancer just 1 day after diagnosis. Valerie Harper, or Rhoda, though most of us in the room probably knew her as that. A television icon whose battle with lung cancer has drawn national attention. And Jewel, the Grammy Award-winning artist who is passionate about this cause. As we launch this important initiative, we have a message from Kelly Pickler that we'd like to share.
Hello everyone, I want to welcome you and say thank you for being a part of this amazing movement called Lung Force. In 2002, I lost my beloved grandmother, the woman who helped raise me, to lung cancer. So the cause of finding better early detection and more treatments for women fighting lung cancer is very close to my heart. Lung cancer is the #1 cancer killer of women in our country. But if we join the fight together, we can be the difference that defeats lung cancer and saves women's lives. For the American Lung Association, Lung Force, and all of our partners, I thank you for raising your voice and standing strong.
Lung Force is a multifaceted national movement, and across the country we are educating Americans, overcoming the stigma, which will be a long road, but we have to start it, raising funds for research and helping women take steps to improve lung health. By taking a stand and raising our voices, we have the power to fight for lung health. And again, I know all of you believe that, or you wouldn't be here. Next, the Lung Force public service announcement featuring celebrity talent will educate women about our #1 cancer killer and seek to destigmatize this devastating disease.
A strong woman can handle any challenge,
But it's going to take a force of women to defeat lung cancer.
the #1 cancer killer of women in our country.
Too many of our mothers, sisters, daughters, and friends are losing their lives. So we've joined the American Lung Association's Lung Force
Because we need all of us.
to fight for better early detection and more treatments and create new hope.
Will you join the force?
And help save women's lives? Fight lung cancer and women at lungforce.org.
So we're fortunate to have such a strong group of advocates and activists here in the metro New York City area, and we hope that we can include you in this force against lung cancer. We know that by rallying together we can make a difference. We're actively looking for volunteers to help lead this effort in the city, and also looking for those who are impacted by lung cancer to serve as mission ambassadors. We have some cards around the room on the table. If you feel so empowered, we would ask you to fill that card out, and we'll be in touch with you to help us with this initiative, Lung Force. Again, we thank you for your time today, and we look forward to rallying together for lung health and against lung cancer. And now it's my pleasure to turn the microphone over to Dr. Tyrone Brown, who is a PhD in health administration and is a graduate of Mercy College's Schools of Behavioral and Social Sciences and Business. He has served as a frontline clinician, administrator, and organizational developer for nearly 20 years, providing services to diverse client and patient populations across the continuum of care. Professor Brown serves on the board of directors of numerous professional education and community health and human service organizations, and his clinical experience includes specializing in diverse populations impacted by chronic and polyoccurring medical and mental health conditions. Since last January, Dr. Brown has served as Interdisciplinary Program Manager at the 1199 SEIU Training and Upgrading Fund Institute for Continuing Education, providing institute oversight, assistance, and support in the research, design, development, delivery, and evaluation of workforce continuing education and licensure and certification exam prep programs, and various workforce and organizational development initiatives. Tyrone, how do you have time for all this? Getting out of breath. We are really honored and appreciative that 1199 SEIU Training and Upgrading Fund Institute for Continuing Education has sponsored this summit, very active in the planning committee, and were critical to getting us here today. And we welcome Dr. Brown to the front to moderate and MC the summit. Dr. Brown.
Good morning, everyone.
Good morning.
Thank you, Jeff, for that wonderful welcome. I want to thank everyone for coming out today. It is an honor for myself to be a part of this program, to have been asked to moderate the program. I just want to thank Jeff, Liz, and the ALA family, Northeast. I want to thank the 1199 United Health Workers East interdisciplinary committee members who have come out today to be a part of this program. If those of you who are in the auditorium can just acknowledge yourselves so that we can see who you are. You have been very instrumental over the years in helping to develop quality programs with the 1199 Training and Upgrading Fund. I also want to thank again my director for the Institute for Continuing Education and my esteemed colleagues for the Institute for Continuing Education. Without their help and support, none of this may have been possible. So I just want to acknowledge them. Thank you very much. And also acknowledge all of you again. So I'm just going to move right along because I know the program is a little bit behind schedule. So before I bring up the first presenter, I would just like to ask everyone to please silence any electronic devices that you may have. Put them on vibrate or turn them off, whatever you're comfortable with, but certainly we don't want to cause any disruptions or distractions during the course of the program. For those of you who may not be aware, the restrooms, the ladies' restroom is outside these 2 or 3 doors here, or to your left and straight ahead. And for the gentlemen, it's the corridor where the elevators was, straight ahead behind the oak doors if you need to refresh yourself. Also, I would just like to let everyone know that if you parked over at the in-park parking garage this morning and you would like to get your parking ticket stamped for the discount, you can speak with one of the program assistants who will be out here in the reception area or at the desk, and we will be happy to stamp your ticket for you when you're ready to leave at the end of the day. Also, I would just like to ask everyone, if possible, to please refrain from questions until the end of the program. We have a session at the end of the program, a panel Q&A, in which all of today's presenters will be part of that panel, and you would have an opportunity at that time to raise any questions or comments that you might have. In the back of your brochures is ample writing space for you to sort of note any questions or comments that come to mind during the course of the day. Again, it's an honor to moderate the program. I will be doing my very best to work with the presenters to try to keep the program as tight and on time as possible. So for the presenters, I will be sitting over here, and I have some time cards. So, you know, if absolutely necessary, you know, I will be flashing you with the running out of time and then you know, time's up cards. And if necessary, please don't get alarmed, but you may see the big cane coming out towards the podium. So I would like to bring up today's first presenter, but before I do, let me tell you a little bit about this gentleman. Neil Schachter, MD, is considered one of the leading authorities on respiratory disease in the United States. Professor of Medicine and Community Medicine and Medical Director of the Respiratory Care Department of the Mount Sinai Medical Center in New York City. Dr. Schachter has served as President of the Lung Association of the City of New York, the Connecticut Thoracic Society, and the National Association of Medical Directors of Respiratory Care. Other credentials include author of 6 books on pulmonary disease and contributions to 16 chapters in medical textbooks, author of 400 articles and abstracts in peer-reviewed journals, holds board certifications in internal medicine and pulmonary medicine, holds the Maurice Hexter Chair of Pulmonary Medicine at Mount Sinai Medical Center in New York City. Dr. Schachter has conducted dozens of national and local print, radio, and television interviews on pulmonary topics that include air pollution, asthma, influenza, pneumonia, smoking dangers, and allergies. He has appeared on NBC Nightly News, The Today Show, CNN Headline News, as well as on ABC, NBC, CBS News programs. Dr. Schachter has been heard on CBS and ABC radio and has been featured in the New York Times, New York Daily News, New York Post, More, Fit, Prevention, and the New York Magazine. It is an honor and a privilege to invite up to the podium Dr. Neil Schachter.
Thank you, Dr. Brown, for all those kind words. It's sometimes hard for me to recognize the person behind the CV. I've been given the impossible task of summarizing for you in 10 minutes the history of lung cancer in the United States and throughout the world. So let me start right away. The story begins, if I can There we go. The story begins 100 years ago at the outset of World War I, as the whole world was changing. Anyone who's watched the BBC series knows that the world after World War I was not the same as the world before World War I. So, at that time, lung cancer was not on the medical map. An extensive review done by a Dutch pathologist who reviewed the entire world's literature on pathology of cancers found only 374 cases with this diagnosis at the time of the outbreak. And recently, one of my colleagues, Jim Strauchan at Mount Sinai, reviewed all the autopsies that were done between 1883 and 1910 at the Mount Sinai Hospital, and for patients with cancer, and this revealed only 6 cases of lung cancer, 2.1% of all the cancer autopsies. So the end of the war brought one of the greatest epidemics the world has ever experienced, the 1919 flu epidemic. In that year, the epidemic turned deadly. 200 million people across all continents were affected, 21 million died, and in the US alone, 500,000 died. However, by 1920, the disease had run its course and the Roaring Twenties began, but a more insidious epidemic was about to start. This chart follows the appearance of cigarette consumption, the use of cigarettes in the United States versus the death toll of lung cancer in men, because initially this was a disease of men over the first 90 years of the last century. Cigarettes came into their fore because a machine that rolled cigarettes automatically was invented, and that allowed cigarettes to be distributed or marketed in great numbers. And as a result, the parallel between these two lines ensued, and as you can see, there's a 20-year difference between the two lines. That 20-year difference is the lag period that's required for the effects of cigarette smoke to cause lung cancer. Today, lung cancer is the #1 cancer killer in the world. It accounts for over 1.5 million deaths worldwide, and in the United States, each year, 160,000 deaths occur. As I mentioned earlier, initially this was a disease almost uniquely of men, primarily because of the way cigarettes were marketed. But in the 1960s and certainly in the 1970s, when cigarette companies were looking for new customers to enter the marketplace, women became the target, and as a result, the numbers of women dying of cancer steadily rose and now is approaching the same numbers as men. It is the #1 cancer killer among women, as you've heard before. Now, cigarette smoking is not the only cause of lung cancer. In men, it accounts for 90% of the victims, but in women, it only accounts for 75%. That difference is not totally understood at this point, but we are working on it. One of the heroes of this war or this epidemic has been Dr. Luther Perry, Surgeon General of the United States between 1960 and 1965, appointed by John F. Kennedy. He was the one who brought together the experts who put forth the first report, Surgeon General report on smoking and health. And since then, there have been dozens of other reports that have followed, outlining all the major ways in which cigarette smoking causes health. And just as a reminder, the New England Journal recently published an article, or 2 articles, showing that cigarette smoking reduces life expectancy by 10 years in both men and women. Now, the good news is that since Dr. Terry gave his report, the prevalence of cigarette smoking in this country has dropped from 45% to 17%. However, the bad news is that for those afflicted, 5-year survival still remains low. This chart just shows that survival is very good in patients with stage 1 lung cancer. That's that dark blue segment on the top row. It's over more than half the people afflicted survive more than 5 years. But once we get beyond that, the statistics drop dramatically. One of the major reasons for this is that lung cancer is often a silent disease when it presents. For better or worse, the lung has no pain fibers. And as a result, we don't sense lung cancer as a painful illness. We only sense it as painful when it reaches the outer lining of the lung, the pleura, which is exquisitely sensitive to pain. As a result of this, lung cancer presents more frequently than not at a late stage in its development. What we want is to find lung cancer at this stage, where you see it as this small white nodule, a centimeter or a centimeter and a half in size, not spread to any other part of the body at stage 1. At this stage, it is potentially curable. The good news is, as was announced in the New England Journal, that the survival of cancer patients, particularly with stage 1 lung cancer, can be enhanced by early detection with CAT scanning. And the investigators leading this international study were able to show that at least 20% of those that ultimately would have been diagnosed at a later stage could be detected earlier if they participated in a lung screening program. The second piece of good news is that we are now in the molecular age of lung cancer treatment, and you'll be hearing more about this as the day goes on. We are now on the threshold of finding better, safer, more specific therapy for this terrible disease. So I'd ask you to join us, not for the beginning of the end, but for the end of the beginning, as we are now starting out on a journey that I think will bring lung cancer into a position where it can be cured. Thank you.
Thank you, Dr. Schachter. Thank you for taking us through that history. However brief the presentation was, we know that the history has been long, and it has been a journey. And as we get closer to resolving all of the issues and problems and circumstances that lead to lung cancer, we hope that everyone will join us in that process moving forward. Speaking of which, today's also a very exciting day for me in another aspect. I will be needing to leave the program before it is finished today, because my 13-year-old son, the baby of 4, is graduating today from junior high school, and so I'll be leaving sometime around the beginning of the afternoon panel discussion. But please know that although I will be pulling out of this program a little early today, I am in this fight to the end, to win, so that we can eliminate lung cancer in all people. At this time, I'd like to introduce our next presenter, who's going to come up and do a testimonial of hope. Dorothea Johnson is a retired licensed practicing nurse. Ms. Johnson is a 71-year-old female and retired LPN. Dorothea believed herself to be healthy when she received her diagnosis of lung cancer. Initially, Dorothea was shocked and found the news that she had lung cancer hard to digest. Dorothea knew immediately she had a critical role to play in her treatment. Her doctors had the necessary role of treating her cancer. Dorothea knew that she had the power to control her emotional well-being throughout her treatment. Dorothea refused to pity herself, to be angry and resentful. Dorothea is a strong believer and passionate advocate for maintaining a positive attitude during treatment, as that is as important as the treatment itself. Dorothea hopes that others can find the tools to keep their spirits high. I'd like to welcome Dorothea Johnson to the podium.
Thank you. Good morning. My name is Dorothea Johnson. Needless to say, I'm looking at all these people. I am extremely nervous. Thank you. I'd like to thank everyone for having me here today. I'm going to briefly run through what happened to me. I was diagnosed with lung cancer in January, I think it was. I couldn't breathe. I was coughing. I had this little slight cough every 2 days. I knew I had stopped smoking, so I couldn't understand this, coughing, persistent. So I went to the doctor, and he put me on some steroids, and it still didn't stop. And I became out of breath. I couldn't walk too long. I couldn't work out, and I couldn't figure this out, So he did an X-ray, and he noted 3 small nodules in my right lower lung, and I had some fluids around my lung. He did a PET scan. There was no metastasis at this time. However, the PET scan wasn't read until maybe 3 or 4 weeks later. I came back to the hospital. My right lung was collapsed. I had about 1,500 cc's in that area, and at that time he diagnosed me with stage 4 lung cancer. He could have tapped me and pushed me over. I was devastated. I was terrified, and they sent me home, and my lung was collapsed. And a friend of mine said, "I'm going to do some research." And he looked on the internet, and he found Mount Sinai Lung Association. He had been there for bladder cancer. He said, "Listen, go to Mount Sinai." And when I went to Mount Sinai, it was so funny. I was introduced to a surgeon, and the surgeon said, "Listen, I'm not an oncologist," but he introduced me to another surgeon, Dr. Wolf. And I'm so grateful that Dr. Wolf, she approached me with such confidence and compassion and care. I just knew I was going to be okay. She did surgery that day. And she admitted me right away. She was so confident. She said, "Look, I'm going to do this right now." And she admitted me, and she did the surgery. And she said, "I'm going to introduce you to an oncologist." And she introduced me to Dr. Smith. I don't want to get emotional. It is so important. The approach that they had was so significant in the way that I responded. These people were caring. They were so compassionate and extremely hopeful. No one approached me with this, look that, okay, look, this is the end here, They approached me with hope. And so I said to myself, listen, your universe is doing something. The doctors are doing something. What are you going to do for yourself? How are you going to deal with this situation? One, I knew that I couldn't be angry. I knew that I couldn't be resentful. And I knew that I could not feel sorry for myself. Those are killers. I knew I had to stay in the moment. I looked to the universe. I started exercising. I started eating right. And I started paying attention to my spiritual condition. I'm just speaking for myself. When I go for treatment every 3 weeks, it is such an experience that a lot of times I don't even realize I have cancer. The atmosphere at Mount Sinai is just unbelievable. And sometimes I told my friend, I said, listen, are these people making believe or what? You know, so the one thing I've tried to do is stay in the moment. I try to live in the moment. I told Dr. Smith, I said, listen, Dr. Smith, don't start giving me a whole bunch of gory details here because I have to have a measure of hope. And my head will tell me some stuff. If I'm all into what's going to happen tomorrow and what happens now and yada, I can't live with that. What I can live with is the moment. And right now, in the moment where my feet are, I'm pretty good. I feel well. My mental health is pretty good. So what I try to do is I approach the day every day, excuse me, I look to the universe, I get myself together and I go to the gym. That's what I do. And I work out. And I come home and I eat right. And I rest. And I try to stay in the moment. And I'll tell you something, I'm not saying because Dr. Smith is here, my team, they're such a wonderful team. You have no idea how important, how very important it is for people to approach you in the way that they approached me. Compassion, confidence, care. I am so grateful to have met these people. I don't even feel like I have lung cancer, you know, but like I said, I stay in the moment. Right now I'm healthy. I've gained weight. I'm kind of strong. You know, I can lift weights, you know, like I like to. And I'm doing okay. So with that, I'll say thank you for having me. I hope I said something.
Thank you, Dorothea, for sharing your experience, strength, and hope, and your spirit with us this morning. There is hope. Lung cancer, having a diagnosis of lung cancer is not a death sentence. Our next speaker. Denise Hogan. Coordinator, POWER, P-O-W, apostrophe R, against tobacco from Rockland County. Denise has been the Rockland County coordinator for POWER against tobacco for the past 8 years. Throughout that time, Denise has fostered relationships with numerous organizations and elected officials throughout the county. Networking with the Chambers of Commerce, Rotaries, and business associations has given her the opportunity to educate the community and garnish their support to decrease the social acceptability of tobacco use. Denise has served as a trustee for the Nyack Village Board and lived in the village all her life, raising her family there. Her role as coordinator gives Denise the opportunity to give back to the village and to work towards positive change. Denise is the mother of 2, grandmother of 3, and a 2007 graduate of New York State's Empire College. I'd like to invite Denise Hogan to the podium.
I too am very, very nervous. This is my story, and yet I wrote it because I didn't want to leave out parts. I didn't mention anything in my bio about lung cancer because lung cancer is not who I am. You can't hear me? Can you hear me now?
Oh, yeah.
Okay. All right. I was a smoker. I started smoking way before we knew that it was going to hurt us. I'm that old. And when I did find out, it was too late. I was very much into my addiction. I tried to quit for 5 years, 6 years, 6 months. Finally, 15 years ago, I stopped smoking. In my 11th year as being a non-smoker, I was diagnosed with stage 2 non-small cell lung cancer. When I received this information, I said to my children, "Who lives with lung cancer?" And then I said, "I do," and so far so good. After numerous tests, I mean the PET scans, CAT scans, MRIs, biopsies, my surgeon, Dr. Pass at NYU, said to me, "You're young, you're healthy, let's take it out." And I said to him, "You had me at young." When I left his office, I went home and I called and emailed several key people in my life, and I said, "I'm already cured." I was convinced that I was going to get through this, and I got through it. He removed the upper lobe of my right lung. The cancer did not spread. It was 5 centimeters, which apparently is quite large. He suggested I do chemo, so for 3 months I did aggressive chemo, and my spirits were not as positive during chemo. I had a very difficult time. But I would get one good day, and that would lift my spirits, and I would soldier on. And I continued to soldier on, and the rest is history. I can do everything I did before surgery. I have a bit of shortness of breath, but not enough to stop me from doing what I want to do. I don't know if there's an upside to lung cancer, but I do know that you don't have to die. Early detection, paying attention to your body, knowing, get to the doctor. I woke up, I had a severe pain back here, and I was short of breath, and I was like, this is weird. I must have done something in the gym. And I was first diagnosed with pneumonia. And then when I went back for a follow-up, that's when everything started. Okay, so what else? I never had a bad experience with doctors, technicians, family or friends. They never did, because you smoked, that's why you got lung cancer. No one did the blame game with me, and no one shamed me. And if we're going to blame someone, I think we should blame the tobacco companies for producing a product. It's a legal product, but when taken as directed, it causes illness and death. I bought into the whole marketing of tobacco. I didn't know how to play tennis, but I thought if I smoked Virginia Slims, maybe I could, because that's how they advertise them. So as I bought into it, I got sick. And that's why my job now is to protect our youth, because that's who the tobacco companies are going after, because they need replacement smokers. So I do picture a new generation of non-smokers. I think someday it'll happen. And in closing, I want to say that lung cancer, it doesn't discriminate. If you have lungs, you can get lung cancer. Lung cancer changes your life in a split second. But for me, and I hope for anybody else, it didn't take my dignity, it didn't take my will to live. And you don't have to die. I believe in divine intervention. I believe that everything happens for a reason, and if it was my time to go, I would have gone. It wasn't my time. I believe in miracles. I kept saying to myself through chemo, my miracle is right around the corner. So believe in hope, believe in yourself, and believe in miracles. Thank you.
Thank you again, Denise and Dorothea, for both of you sharing your experience, strength, and hope, and the message that having lung cancer is not a death sentence. There is hope, and there is life after a diagnosis of cancer. Moving right along, I would like to bring up our next presenter, who's going to be presenting on how to navigate the psychosocial aspects of lung cancer, a very, very important topic. Batya Rexon, licensed clinical social worker, oncology social worker at Mount Sinai Medical Center. Batya is from South Africa. She has a master's degree in clinical social work from the University of Cape Town. Batya has many years of experience in the treatment of traumatic disruption in children and adults. Since immigrating to the United States in 2007, Batya has worked in the field of medical social work. For the past 4 years, Batya has been working with head and neck cancer and lung cancer patients and caregivers at Mount Sinai Medical Center. Batya also serves as the Community Outreach Coordinator for the Tisch Cancer Institute. She is in her 3rd year of the Annie Bergman Parent-Infant Training Program at the Institute of Psychoanalytic Training and Research in New York City. Batya lives in Brooklyn Heights and is a mother of 3. Please join me in welcoming Batya Rexon.
Thanks, Tyrone. Thanks, everyone. Can you hear me a bit louder? Good. So, as already introduced, my name is Batya, and I work at the Tisch Cancer Institute at Mount Sinai Medical Center. And today I'm going to talk about the psychosocial aspects of dealing with lung cancer. I'm going to talk about the common challenges that people face when dealing with lung cancer and give to you some resources, lists of resources and services to help you navigate your way through this journey. And the journey I've divided into 6 different intersections or parts, starting with diagnosis and ending with establishing the new normal. And just to say, important to emphasize here that this isn't a recipe on how to cope with lung cancer. Whatever gets you through the treatment effectively, that's the right way. What's most important to understand is the experience of dealing with lung cancer, living with lung cancer and hopefully living without it, understanding that so that we, the providers of care, can provide you with the right resources and services right from the beginning, from the time of diagnosis. Many people tell me when they're first diagnosed, they just don't know where to start. They talk about tremendous shock, as Dorothea and Denise both described. They talk of feelings of disbelief, of fear of not knowing what the future holds for them, fear of dying, fear of financial burden, just not knowing what this diagnosis means for them, for their families, for their future. Feelings of loss of control are often described to me, not knowing what to expect from the future. It's important to give yourself time to adjust. It is an emotional roller coaster. If you can, find someone also to know that psychologically, anxiety is very normal at this stage. And if you can, get emotional support. If you have someone to talk to, whether it's a family member or a friend or a professional service, just hearing that it's going to be okay, that there is help, there is support for every stage of this disease. There's treatment for any stage of this disease, can be very comforting. If you have someone to come with you to your appointments, 2 sets of ears is always better than 1, particularly when you're feeling anxious. Sometimes when you're very anxious, you just can't think straight. So all these small things can help with putting one foot forward. And following is a list of agencies and non-government organizations that are dedicated to providing help and support to people with lung cancer. Counseling support, this is provided over the phone, face-to-face, online, in a group sessions, individual sessions, caregiver support, even if it's just information that you're looking for. Again, use these resources in a way that's right for you. Some people like to find out everything they can about the disease. They feel this helps them overcome the fear of the unknown. Others, like Dorothea, don't want to know. They're happy just to find out about the psychosocial supports and practical supports that are available. Getting to know your oncology team is another important resource. You know, the oncology team is made up of people from different disciplines, and each are dedicated to addressing your personal needs and to helping you get through this time. And just to quickly go through who your team is, the 3 medical specialties is the thoracic surgeon, the medical oncologist, the radiation oncologist, the supportive oncologist, who can be seen through referral. The little pink R's means through referral. And the role of the supportive oncologist is to help manage your pain, help with symptom management, help maintain quality of life. They work very closely with the team, the oncology team, with social work. They work closely with chaplaincy, with integrative services, and can be seen from the onset, from the time of diagnosis. The nurse practitioner, that's a highly specialized nurse who's trained to give medical advice, to write prescriptions, works very closely with the oncologist and follows you throughout the treatment process. Your nurse is your coordinator, your navigator. She's the one who can tell you where you need to be, when and why, and talk to you about the treatment, any questions you have about your medications, any concerns, and refer you to any one of us. The dietitian, for people who have questions about their diet, what to eat, how to stay nourished through treatment, the dietitian is available to guide you through that. And the social worker is available to help address your psychosocial concerns. I often feel that the service is not known well enough, that people don't know what to expect from their social worker. So I just want to go through quickly with you what you can expect: supportive counseling, information resources, referrals to agencies, both services within the hospital and in the community, practical concrete support as well, information and referrals to organizations for providing financial assistance. Many people aren't even aware that they're eligible for financial help. So it's important to ask to speak with your social worker. Assistance with your Social Security disability application, meal delivery services like God's Love We Deliver, transportation, pharmaceutical assistance, medical equipments, and home care referrals. So your plan of care, so the treatment, treatment is usually determined by many factors, not the type of lung cancer you have, the stage of the disease, where it's located, your age, your general health, will all determine what the treatment will be. It usually involves 3 modalities that can be administered either together or separately, and that's surgery, chemotherapy, radiation. And once decided, often there are tests that need to be conducted, so you don't know your treatment plan right away, but once it is decided, it is discussed with you in depth. And this is the time, if you're looking to get a second opinion, do it now rather than midway through treatment. And the other 2 points that I've put down here emerge really from a survey that was conducted by the Association of Oncology Social Workers, the AOSW, which found that 60% of people reported that they were not financially prepared for the burden of a cancer diagnosis. 7% said that they were completely prepared. And the 3 major stresses identified was reduced income, financial needs, health care, not having full health coverage, and logistical support. And that can refer to your informal supports and transportation, just getting to and from the medical center. So I want to go through some of these support services that are available for you. Again, these are organizations, non-government organizations that are dedicated to helping people get through their cancer treatment and helping them with financial assistance, with chemotherapy, with radiation, with medication support, as well as non-medical support issues as well, help with rental assistance, with home care. Again, go through the list, and if you do have any questions or you want to ask me about anything, please feel free to ask during the question and information session. For patients needing free legal advice, these are organizations that assist with providing legal advice. Some meet with you in your home. I think that's the Family Center. A counselor can come to your home. Others provide help over the phone, or you go into the office. In terms of accommodation and transportation, so the American Cancer Society and Miracle House are two excellent resources that provide accommodation for people traveling to New York City for their treatment. Hope Lodge provides complimentary housing throughout your treatment, and it's for the patient and the caregiver. And Miracle House, it's low-cost housing. I think it's like $50 a night, also for patients and caregivers. The other two resources, Hospital for Family and Friends and ITM Hospitality Fund, provide small grants for staying in a hotel for 2 nights or 4 nights for people coming in for second opinions. Aside from Miracle House, all the referrals are made through social work. Transportation, Accessoride is a public transportation service that is available to cancer patients for the cost of a subway ride. They take you door to door to treatment and back. Amtrak and the Hampton Jeepney provide discounted services. I think you get a 15% discount on your tickets, and the C Street Ferry provides free transportation, and that's coordinated through the American Cancer Society. So getting through treatment. Often when people are getting through or trying to get through treatment, they put things aside and they don't have as much time for their family members, which is perfectly normal. Relationships can go through strain. Children often act out. Intimate relationships may suffer. And it's important to know that there is support. There is supportive services. There's counseling, and not just talking about feelings as well. There's help with doing and with helping you put one foot forward. Supportive oncology is available to help as well with symptoms and with side effects of treatment, with fatigue, with discomfort. And this also applies to caregiver support. Caregivers fill a fundamental service. They provide so much for patients, for their loved ones. Emotional, psychological support, logistical support, bringing and taking them, hands-on care. And so often when a caregiver is stressed out, this impedes on the ability to help and can impact negatively on the patient as well. Because of the adjustments that families make and caregivers make to help loved ones with cancer, they're often referred to as the second-order patients because of the stress levels. So it's so important, again, to take care of yourself if you are a caregiver, to use the resources, American Cancer Society, the Gilda's Club, Cancer Care, your social work department, your supportive oncology department as well. And often, when we are coping with our emotions and we're reflecting on ourselves, we do think about the judgments that we hold of ourselves and the judgments of people around us. And one of them, which I frequently hear, is you deserve cancer because you smoked. No one deserves to get lung cancer. No one deserves to be judged at their most vulnerable time and to feel isolated. It's repulsive that people do this, and it's so important that we stand up against that. Another, just to say, it affects both smokers and non-smokers. For non-smokers, they can feel as betrayed. Why have I got lung cancer? I never smoked. I ran marathons. I wish there was a way we could just raise awareness. I was thinking this morning if we could just make T-shirts, 1 million T-shirts saying, "I love someone with lung cancer and she's innocent." Or "I'm battling lung cancer, I'm innocent," just to get people to think about their judgments and what this does to people. And another stigma that's spoken a lot by Dr. Jimmy Holland, who is a psychiatrist and a pioneer in the field of psycho-oncology, is around getting psychosocial help. She says how so often patients will tell her that they think it's a sign of weakness, it's a sign of that they're not coping, that their family will think they're not coping, it's a poor outcome for them. It's not true. There is help. There's help for anxiety, there's help for depression, there's medication, there's counseling, again, there's the support of oncology. And everyone is available to help you get through this time. And lastly, after treatment and establishing the new normal. So completing treatment really is a significant time. It's a time of celebration, it's a time of waiting as well. But you've made it through your treatment. It's time to treat yourself. If you haven't already gone to a Look Good, Feel Better session, I highly recommend that through American Cancer Society. This is a beauty consultation. They provide you with free skincare and beauty products. It's also a stressful time. It's a time of waiting. You're waiting to feel yourself again. You're waiting to get your test results to see how your treatment how successful your treatment has been. It's also about establishing your new normal. Cancer, it changes you. Your life is never the same as it was before you were diagnosed. Sometimes you're making changes in your life, changes in the way you eat, changes in the way you do things. And this is how introducing these changes and bringing them into your life is how you establish your new normal. So often people will tell me that they're not willing to tolerate some of the things they would put up with in their relationships before they were diagnosed. So it's a time of reevaluation as well, reevaluating your work, reevaluating your support systems. And it can also be a lonely time. It can also be a difficult time. It's not just about living with hope, it's also learning to cope with uncertainty, with not knowing, will my cancer return, or will they find the right treatment to treat my cancer? So it's so important to give yourself time, to be patient and to be gentle with yourself, and to know that there is support and that you're not alone. Thank you.
Okay, we're going to have our last AM presentation, and then we're going to have a break, and then we will come back together after the break for the afternoon session, which will include another presentation and then a panel Q&A. At this time, I want to introduce our next speaker, Cardinal Smith, Assistant Professor of Medicine, Hematology and Medical Oncology, the Tisch Cancer Institute, and Brookdale Department of Geriatrics and Palliative Care Medicine. Lillian and Benjamin Hertzberg Palliative Care Institute and Icahn School of Medicine at Mount Sinai. Can you hear me in the back? I'm terrified of this thing right now. It's making some strange sounds. Dr. Smith is a graduate of Drexel University School of Medicine and completed her internal medicine residency and integrated hematology, oncology, and palliative medicine fellowship at MSSM, where she served as chief fellow. In addition, Dr. Smith has completed a Master's of Science in Clinical Research at MSSM and is currently the recipient of a Clinical and Translational Science KL2 Scholar Award and is working towards obtaining a PhD in clinical research with a focus on outcomes research. Her research interests include evaluating treatment disparities in care and outcomes of patients with lung cancer, in addition to evaluating determinants of cancer patients' quality of care, characterizing barriers to optimal patient care, and developing approaches to eliminating those barriers. I'd like to invite up Dr. Cardinal Smith.
Thank you, Dr. Brown, for pronouncing my name correctly. I appreciate that. And I recognize that I am in the unique position that I am what's holding you from lunch. So I will try and keep you entertained and interested in what it is that I have to say. So I had pictures up there, and it was my story, and so I'll start with my story. And then the first picture was a picture of me on my wedding day, which was September of 2005. Actually, I'm glad it's not up there because it was a younger, pre-baby, thinner version of myself, along with my father. And obviously, it was a good day. It was my wedding day. And that was September of 2005. Then in April of 2006, I got a call from my grandmother telling me that my dad wasn't feeling so well and he was noticing some blood when he had bowel movements. And so I was a resident at the time, an internal medicine resident, and we got him checked out, and he was eventually diagnosed with stage 4 rectal cancer. So he was diagnosed with cancer, he was treated, and we were fortunate enough to be at an institution where he could be seen by a supportive oncologist, also known as a palliative medicine physician, and we'll talk about that in a little bit. And he was able to do things with treatment that most people probably didn't think he would be able to do. So we're from Belize. He was able to make several trips to Belize to enjoy his time to vacation. A year after I got married in September of 2006, he was there to see his first grandchild born, not mine, my sister's child. And there is a picture that I had up there of him with her on the sofa. And so despite being through treatment, he was also receiving supportive care that really allowed him to manage the symptoms of not just the cancer, but the treatment itself, and gave him a good quality of life and time to do the things that he wanted to do and the time to spend with his family. Because really, what's the point of going through cancer treatment if you can't have quality of life during and after? And so that's why I'm passionate about what I do. So folks with lung cancer have several concerns. They have many symptoms, either from the disease itself or from their treatments. And these can include the most common things we tend to see, which is cough, shortness of breath, pain, fatigue. There may be some nausea and vomiting, anorexia, just meaning, loss of appetite, not able to eat, and maybe some depression or anxiety. And of course, their caregivers, particularly their informal caregivers, their loved ones, also have concerns. How do I safely take care of my loved one who's going through this? What is it that I can do for him or her to make it easier on her? What can I do to make it easier on me? And so that's where supportive oncology or palliative care comes into play. And so how many of you have heard of palliative care? Okay. And how many of you equate it with end of life? Okay, so a few. All right, good. So hopefully at the end of this talk, I will make you feel differently. So palliative care really is a specialized medical care, and it is new, was really developed somewhere in the 90s. It did come out of the hospice movement, but is now a board-certified training fellowship. And is a particular subspecialty field in medicine and others. And it really focuses on providing patients with serious illness, provides them with management of symptoms, pain, or otherwise, and it's specialized medical care, which goal is to improve the quality of life for both the patient and the caregiver. It's provided by a team of doctors, nurses, social workers, of which I am fortunate to have great social workers who work with me. 2 are in the room right now, so thank you. As well as other complementary services, so massage therapy, yoga, art therapy, music therapy. We have chaplaincy, psycho-oncology services. So really an interdisciplinary approach to taking care of the whole patient. And the most important thing to remember about this, if you don't remember anything else, is that it is important for patients at any stage of illness, whether they are getting curative or life-prolonging treatments. So it is given simultaneously as curative and life-prolonging treatments. In practice, what it looks like is really expert symptom management, expert control of pain, nausea, vomiting, shortness of breath. It's coordinated care to help people easily transition through what I would call a very fragmented medical system. You know, you're getting cancer care, you're on insulin for your diabetes, I'm giving you steroids, but I'm going to send you to your diabetes doctor to manage that sugar. It can be really hard sometimes in our system to manage and negotiate all of the things that you have to as a cancer patient. And it provides practical support. So Batya mentioned a lot of what practical support is. It really is an assessment of who you are, what you have in your home, who you have to help you, and how can we make it better. What that looks like in real life, and I want to thank Dorothea for her kind words that she said to me, but what it looks like in real life is, hopefully you won't mind that I share this with you. Dorothea, she juices, and even though she's tried really hard to convince me to do the same, she's not winning that battle. But you know, she does go to the gym several times a week, and she weight lifts. I can't even get to the gym once a week. And so when I first met Dorothea, she told me what was important to her. And she told me, you know, I want big picture of what I have. I have stage 4 cancer, fine, but I'm hopeful, and I want you to hope with me and walk on this journey with me. And we talked a lot about what it was that she was hoping for, what it was that she was looking for, and we made plans. You know, let's get a healthcare proxy. Who's the person you want to help make medical decisions for you if you're ever unable to do it for yourself? Those things are important for everyone to have. I have one. You know, you think about what your own social situations may be like. I have patients who are currently married, but they haven't been with their partner for more than 10 years. And yet in New York State law, if something happened to them, that's the person I'm legally required to go to help make medical decisions for him or her if they're ever unable to do so for themselves. That may not be the person you want to make those decisions for you if you haven't been with that person for 10 years, right? I mean, so those things are important. It is also knowing that she prefers a holistic, alternative type therapy as much as she can, realizing that obviously medical, Western medicine and treatments are important. And so when she tells me about what's bothering her, we try to come up with ways in which it's not just me writing a prescription for her to go to the pharmacy to fill it, but if there are potentially treatments that are complementary to what she has and won't alter the chemotherapy she's receiving in any way, that's what we provide. That's what I provide for her. And so there's this old model, sort of 2 types of care. It's like a fork in the road. So you could go one way and you could get aggressive medical care, chemotherapy, and others. Or the other way was you could get palliative care or hospice care. And so what that really looked like was this old cure care model, which is that you're going along the continuum here and you're getting curative or life-prolonging care, and then all of a sudden something happens, and then you get either palliative or hospice care or a combination of both until you die. And I think that's a really bad model because we're not really helping people give the best quality of life and the best relief of suffering that they can have. And so what we hope can occur is that while you're getting this disease-modifying therapy, whether it's for cure or for life prolongation, you're also getting palliative care so that you can treat your symptoms, you can get the practical support that you need, you can get the help for your caregivers, and if it becomes, and if is necessary, you could then move on to hospice care. And so what we hope that looks like is that there is a more seamless integration between life-prolonging or curative therapy with palliative care. So palliative care is excellent evidence-based treatment. So the same way I've got a bunch of data that I can tell you about the way chemotherapy is supposed to work for your lung cancer, I have data to tell you about the medicines that I have available to you to treat your pain, your shortness of breath, your fatigue. It is vigorous care of pain and symptoms through illness. So this is an emergency for me. And it's care that patients get at the same time as efforts to cure or prolong life. It is not giving up on someone, so your doctor sending you to see a palliative care doctor or a supportive oncology doctor isn't because they feel as if there are no other treatments to offer. It is not in place of curative or life-prolonging care, it is together with. And it is not the same as hospice or end-of-life care. So I'd like to think of palliative care as sort of a bigger umbrella, under which hospice certainly is one component, but then there's non-hospice palliative care, which makes up a much larger component. And so the Center to Advance Palliative Care and the American Cancer Society in 2011 did a public opinion poll, and they surveyed folks to see what they knew or have they ever heard about palliative care. And you can see the vast majority of folks weren't at all knowledgeable about what it was, and a small, only 5% said they were very knowledgeable, and 3% said knowledgeable. But yet, when heard the definition of palliative care, which is the same one I showed you in one of the beginning slides, the vast majority said that they thought it would be important for patients with serious illness and their families to have it, now that they know about it. They thought that they would want it for themselves or a loved one if they were ever faced with a serious illness, and they thought that it was something that should be made available for people. And so why is it important? Well, we know that we're making, sorry, this has a really bad squeak, but we know that patients are living much longer with serious illness, particularly with lung cancer. We're getting better and better treatments. We're turning these diseases into chronic diseases in which people live longer, but with every new therapy, with every effective treatment, there is a potential for more side effects, more suffering, and more burden. And so that's why palliative care is becoming really important, because it is a way to help folks get those life-prolonging or curative therapies, and yet dealing with the side effects that now exist as a result. So patients and families tell us that they want relief of suffering, they want practical needs for support, they want open communication, they want to be able to talk to their doctors and their healthcare providers about the things that are bothering them. And they want to have opportunities to talk to their loved ones about the things that matter. So clinically, I think we've talked about that there's a need for better quality of care for patients with serious illness, particularly lung cancer. And so in this cartoon, you see here a wizard talking to an elderly man with a cane. And the man says, "Do you have anything that stops the aging process?" And the wizard says, "Sure, what kind of disease would you like?" And so really a lot of what we're dealing with palliative care was born out of this study, the SUPPORT study, which was done in the mid to late 90s, so 20 years almost already. And they went to 5 major academic medical centers in the US, and they surveyed patients about their experiences, particularly with symptoms. And what this slide shows you is that for these diseases here, they queried a total of a little more than 5,000 patients and assessed how many of them were still in moderate to severe pain 8 to 12 days after already being in the hospital. So being in the hospital for a week to 2 weeks, how many of you still experience moderate to severe pain? And those are the numbers. And so it got lots of headline in the news, and it was a big deal that, we really need to do better, and that we're not that great at controlling patient suffering. So palliative care is concordant with family wishes. So when we query family members after a loved one's death and we ask them, what is most important? What is it that you would have liked to seen that you didn't get? The top was that loved ones' wishes were honored, that they were included in the decision process, that they had support at home to help. The practical help, the personal care needs, honest information. You want to know exactly what to expect and what's going on, to be listened to, and privacy. And so here you see a doctor telling a patient, there's no easy way I can tell you this, so I'm sending you to someone who can. So it may surprise you, but I went through medical school training, residency training, a good part of oncology training, and I never really learned how to manage someone's symptoms. I never really learned how to communicate with someone. So I can tell you how morphine works and what it breaks down and metabolizes into and when you should give it to someone or when you shouldn't based on if their kidneys or their liver's working. But I couldn't tell you the best way to actually give it to someone for them to have relief of their symptoms. And similarly, people think that doctors are born with a good bedside manner and are good communicators, or they're just bad communicators. But that too isn't true. These are things that can be taught and things that can be learned. And that is something that we are taught and that I did learn becoming a palliative medicine expert. And it's not that your oncologist is a bad person or that the oncologist is unable to do these things. But in medicine, we live by a see one, do one, teach one model. And if what you saw was bad, then what you do is bad, and what you teach is bad. And so there is a big movement that, yes, there are expert palliative medicine doctors whom oncologists may need to refer their patients to, but even more importantly, those oncologists need to have primary palliative care skills to be able to adequately take care of their patients. Because as an oncologist, my patients trust me and want to come to me to help them with what they're going through. And so we know families want to talk about prognosis. Some patients also want to talk about prognosis. It's important. I know Dorothea just because she's not one of them, and that's okay. In palliative medicine, we meet a patient where they are, and so Dorothea isn't there, and she just got good news. Was it 2 weeks ago already? Time flies, and that she had a recent scan, and her cancer has responded very well to her chemotherapy. So much so that she left and came back 45 minutes ago because she didn't believe me, and she wanted me to tell her again and print her out a copy of her report. But one of the things that I have learned as a palliative medicine physician is I don't need to beat Dorothea over the head with numbers or statistics. I need to take care of her, meet her where she is, form a relationship with her, and when we need to get here, we'll get here. Is that right? Yeah. And so, the majority of surrogates feel that avoiding discussions about prognosis is unacceptable and isn't a good way to maintain hope. As doctors, we always struggle between I want to give my patient hope, but at the same time, I need to give them the information that they need to prepare and do the things that are important. And it's a fine line, and you can always hope for the best with someone, and yet let's talk about what happens if things don't go the way we want them to go and things don't go well. What might that look like? And so hospital-based programs, palliative care programs in the United States has exponentially increased since 2000. We know that the vast majority of large 300-bedded hospitals have a hospital-based palliative care program, and 100% of all of the NCI-designated cancer centers have an outpatient palliative care program. We don't really know what the outpatient supportive oncology programs look like. Or what they're made up of, because those things don't yet have to be reported, but people recognize the importance of it. And this is a map of the United States, and the Center to Advance Palliative Care every couple of years comes out with this, and they gave the nation a report card of a B a couple of years ago in terms of the ability to access palliative care or support across the country. And there are only 5 states that got an A grade. You can see in New York here we got a B grade, but we're moving towards an A for the next report, so I think that's a good thing. And then, most importantly, things that people like to see are data. So in 2010, this seminal study for palliative care was published in the New England Journal of Medicine, and this was in lung cancer patients. So these were patients with advanced stage lung cancer, and they were given active therapy towards their cancer at the same time as receiving supportive oncology or palliative care, the same time. And what they found was that those folks who got both had improved quality of life, had improvements in depression scores, and although this wasn't a primary endpoint, there seemed to be a trend towards an improvement in survival, so that the folks who got both lived 2.3 months more than those who did not. And I will tell you right now, is that if that was a drug for lung cancer, everybody would be getting it, and everybody would be on it, and everybody would be paying for it. And so I think that, whether or not that will truly be borne out as a primary endpoint in the study, we still have a couple of years to find out. But I think palliative care supportive oncology makes a big difference, particularly in patients with lung cancer. And interesting to note that the folks who got both, they got the same amount of chemotherapy, they were enrolled in the same amount of clinical trials, so they did not get any less than treatment than the folks who do not get palliative care. And our oncology professional societies are recognizing and favoring that we integrate palliative care early into the diagnosis of cancer, so that the National Comprehensive Cancer Network, which is where a lot of oncologists get their guidelines for cancer treatment, recommends it. The American Society of Clinical Oncology recommends it, and the Commission on Cancer also recommends it. So what does this mean for patients? Well, I like to think of it as an extra layer of support. It is an extra layer of making sure that you get the symptoms that you need managed appropriately and in a timely manner so that there is no suffering. It helps you navigate a complex medical system, helps you come up with a plan of care. You can coordinate and control care options, can get practical and emotional support both for yourself and for your caregivers, and you can get all of this while you are getting your curative or life-prolonging treatment. But it's really important for docs too, because it can help save time. Sometimes if you're not an expert at managing someone's significant pain, it's hard to do it. And so you can send your patient to someone who can. It is also support. I mentioned before, it's hard sometimes for doctors to deliver bad news, to say the things that are really difficult to say, and it's nice to know you have someone collaborating with you who can help you consult on a patient's care and help you break that bad news in a way that meets someone where they are. And satisfaction. So we know that both patients' families as well as physicians who receive palliative care tend to be more satisfied with what they do. And so, in summary, palliative care improves quality of care for our sickest and most vulnerable patients and families. And serious illness is a universal human experience, and palliation is a universal health professional obligation. And I'm going to leave you with I have one more slide after this, but there's modern medicine and cancer treatment and hospice when that's no longer appropriate. And I like to think of palliative care as something that encompasses the two. There are just some resources. Batya gave you a bunch, but focused specifically on palliative care. There's getpalliativecare.org, which is a website you can go to look for palliative medicine specialists in your area. Caregiver.org, which is a really great caregiver website that provides support for you as a caregiver. The American Cancer Society Cancer Action Network, which is a policy arm of the American Cancer Society who really has taken on palliative care as something that is truly important for them and important for those folks with cancer. And they have several bills right now in Congress trying to introduce legislation to increase the workforce of palliative medicine and to provide more education for all docs in palliative care skills. And then there's the Center to Advance Palliative Care, which also has literature on what palliative medicine is. And so, if you will indulge me a bit, this quote is a little bit of how I think of what I do sometimes, which is when we honestly ask ourselves which people in our lives mean the most to us, we often find that it is those who, instead of giving advice, solutions, or cures, have chosen rather to share our pain and touch our wounds with a warm heart and a tender hand. The person who can be silent with us in a moment of despair or confusion, who can stay with us in an hour of grief and bereavement, who can tolerate the not knowing, the not curing, and face with us the reality of our powerlessness, that is a person who cares. So thank you very much.
Thank you, Dr. Cardinal Smith. What an informative morning we've had. We've had information sharing. We've had expressions of hope and faith and belief. We have been informed that a diagnosis of lung cancer is not a death sentence. It is simply an opportunity to fight the good fight and continue to move forward and continue to live. There is life after a diagnosis of lung cancer. I want to thank the ALA of New England, the President and CEO, Jeff Seeler, for joining us today and presenting us with that wonderful welcome this morning. Also, Dr. Neil Schachter, who took us on a historical view of the history of lung cancer, and he was able to take us over a course of many, many years in a few brief moments, but I think that his message came across loud and clear, that it has been here, it is here, but we are all here today together because we are working together to remove it as part of the future. I want to thank Dorothea, and I want to thank Denise Hogan, and Dorothea Johnson, for sharing your experience, strength, and hope this morning. I was definitely touched, and I just, again, want to thank you for being very candid in sharing that part of yourselves with us this morning, and I'm certainly inspired. I want to thank Batya Rexon, licensed clinical social worker, who presented on how to navigate the psychosocial aspects of lung cancer, which is critical because, lung cancer or any type of cancer is not just a medical illness. It is something that impacts across the biopsychosocial, and as someone mentioned earlier, it does have a spiritual component as well. And I want to thank Dr. Cardinal Smith for our last presentation on integrating supportive oncology after diagnosis. Good afternoon, everyone.
Good afternoon.
Welcome back, everyone, to the American Lung Association of the Northeast Lung Cancer Summit. Again, my name is T. Thaddeus Brown, and I am today's program moderator, and again, I am honored to be fulfilling this role for this very important activity today. Once again, I want to thank the American Lung Association of the Northeast for partnering with 1199 Training and Employment Funds, the Training and Upgrading Fund, Institute for Continuing Education on this event. So before we start the afternoon, I just want to remind everyone to please silence your electronic devices. Just as a reminder, anyone who will be needing the discounted parking stamp for M-Park, parking across the street, please see someone at the front desk here, and they would be happy to stamp your ticket for you. We had a very informative morning this morning. We had several fantastic presenters, starting with Jeff Saylor, the CEO and President of the American Lung Association of the Northeast, as well as Dr. Neil Schachter. We had some expressions of hope and spirituality from Dorothea and Denise, and we had presentations by Batya and Cardinal, Dr. Cardinal Smith and Batya Redman. So, at this time, we're going to bring up our next presenter, who is going to talk to us a little bit about some of the myths and some of the erroneous thinking that elements of society have in terms of what lung cancer is and what it is not. And then we'll have an afternoon panel discussion where there will be ample opportunity for you to ask questions and make comments. Mark G. Chris, MD, is the attending physician at the Thoracic Oncology Services at Memorial Sloan Kettering Cancer Center and lead physician for the Memorial Sloan Kettering IBM Watson collaboration. He's a professor of medicine at Weill Cornell Medical College. And those are just a few of his many, many roles and responsibilities. I could go on and on. Dr. Chris is a medical oncologist specializing in the care of persons with cancers arising in the chest, including lung cancer, thymoma, metastasinal tumors, and cancer of unknown primary site. Dr. Chris's research interests include tests for new anti-cancer treatments, the discovery of medicines that specifically attack lung cancer, multimodality therapy, such as using surgery, radiotherapy, and chemotherapy together to destroy cancers, and better ways to control physical symptoms caused by cancer and cancer treatment. Dr. Chris is particularly interested in finding ways to select the best treatments for persons with cancer based on clinical factors and the molecular characteristics of their tumor specimens. At this time, presenting on breaking barriers in the fight against lung cancers, I'd like to introduce to you Dr. Mark G. Chris.
Hope how am I doing on the microphone? Can you hear me in the back? Okay. All right. Well, I appreciate the opportunity today to speak about this topic, and I'm going to have some tough acts to follow here, everybody at this table. I'm showing a lot of slides, and please don't be intimidated by that, and I ask you to please not try to follow along. What's there is there. But because I'm showing these slides for kind of different reasons than you might expect by just looking at them. And I think this is an extraordinary time for this illness. I think finally, at least in the medical profession, we've gotten on the screen of others that the way we do things is a way that can enhance the care of everybody with cancer. And that the way we've done things in the last decade is really a way to accelerate development and leverage opportunities that we have now to help everybody with cancer, not just people with lung cancer. And I hope to get some of that across today. You know, the topic of the stigma, I'll get back to it a few times. It's quite real. And we, as a group, and I hope a lot of you here that come at this from different angles, you really need to talk about what we can do about it, because it really holds us down. And we just have to deal with it, and we just have to find a way to get on people's screens. We probably aren't as successful in doing that so far, but those of us that work in this field are unbelievable optimists. I heard a great comment the other day. Are you a glass, no matter if the glass is half full or the glass is half empty, you still got to do what you can with the water in the glass. And I think I really like that, and I think that really says it all. You can decide what kind of person you are. So I'm going to talk about the face of lung cancers. I got to say a word about screening, and this is a great example of the I'll call it bias that we face. That lung cancers, believe it or not, are leading the way to personalized medicine. And some words about survivorship. It's amazing that no one ever talks about it. Have you ever heard about survivorship in lung cancer? We had a slide that mentioned it. But as a department, as an academic, there you go. Nope, I guess they don't want me to talk about it. All right. So just a couple of facts. We've heard some of these before. But let's get down to number 4. I think one thing that people don't necessarily focus on is when people are attacked by this illness, they're people in their prime. They're leading their family, they're leading their community, and it's so abrupt. It's really out of the blue. And I think we heard some of that today. You kind of had the rug pulled out from you. We have to talk about the smoking thing because when you look at everybody with this illness, smoking is involved. But as many of the speakers said already, it's a lot more complicated than that. Now I talk about the nuances of that and suggest some ways to move forward. What are the other causes? Well, other than a few very specific occupational exposures, working in an open uranium mine, working in a deep coal mine with high natural radon concentrations, directly working with asbestos, like the person making the potholder. And those are really rare occupations. Those things can cause lung cancer, but they're really, really rare. The other things we really don't know. So we know the cause. But of course, we got to get rid of cigarette smoking. Smoking prevention is great. But just as a rule here, the Centers for Disease Control, I believe, spend about $100 million a year on smoking cessation. So I thank them for that. Let them spend that money. But we need money to fight lung cancer. So people are doing that. American Cancer Society spent a lot on that, and God love them for it. But today it's about lung cancer. We want to, of course, prevent lung cancer. And remember this, though. If everybody stopped smoking today, and I think we saw that 20-year lag time curve before, that curve is still there. The people that smoked 20 years ago are going to risk for lung cancer. And if everybody stopped smoking today, we would still have an epidemic by its, a strict medical definition for, I believe, 20 years to come. It would fill the definition of epidemic. So for those people that say, just stop smoking and the problem is solved, absolutely not. Absolutely not. And again, it's a huge number of people that are going to be at risk. And I guess I need to modify that slide a little bit. It's slightly out of date. But the truth is there's still 40 or so million people smoking here in the U.S. So that 20 years out, those 40 million are still going to be facing lung cancer. And there is no safe amount of cigarettes. There's no safe number. So just a couple of facts. I think we saw this earlier. Equal numbers of men and women. People talk about lung cancers in the elderly. Well, the average age of a person with lung cancer is 71. So that is the person we're trying to help, and everything needs to be put into context as being appropriate for folks of that age. And again, if you don't remember anything else I said, remember this. 84% of people at Sloan Kettering today that are diagnosed with lung cancer have either never smoked or stopped smoking, often decades before. 84% of people are non-smokers, or whatever you want to call them. And this is the data from our institution. So again, this idea that it's all about smoking, you get people to stop smoking, everything is fixed. It's a good thing, don't get me wrong. The fewer cigarettes you smoke, the better. You lower your risk of lung cancer, but it will not solve the problem. This is one of those things that, I don't know, maybe somebody has some more reasoned thought on it than I. So I listened to this press conference. It wasn't that the NCI announced it in 2011. The NCI announced this on November 4th, 2010. The director of the NCI said, this is a big deal. So what did I do? I immediately called up the head of my hospital and said, we have to do this for our patients. And he said, fine, but follow all of your institutional things. But as you saw, nobody else said fine. We are still yapping today about doing this. It's unbelievable that we have had this information out for almost 4 years now, and where we are today. You know, there's all kinds of quibbling about this, but here's the bottom line. Your tax dollars paid somewhere between $250 and $500 million to study 53,000 people to prove that if you could do these low-dose scans for just 3 years, you would lower the risk of these folks from dying of lung cancer. Very, very clear, clean trial, and saying 20%. And guess what? When they did it, that's exactly what they found. If you did those 3 scans, the chance of dying of lung cancer was cut by 20%. And that's absolutely huge. You know, for a woman with, and forgive me for this analogy, if anyone wants to yell at me, you can do it later. For a woman of average breast cancer risk, you have to screen 800 women for basically a lifetime to prevent 1 death from lung cancer. 800 to 1 for a woman with average risk. For a person in this group, it's 1 in 300, 1 in 298. If you take the LST entry criteria, again, it's pretty strict. 30-pack year smoking, age 55 to 74. There are 8 million people fitting that description. 8 million people today. And my guess is that less than 500,000 are actually screened. I don't know if anybody has a better estimate. So again, just to review who it is, it's 5574, pack a day for 30 years. It's 3 scans, low-dose helical scan. Can be done anywhere. It's not a fancy machine. Any CAT scan in America can do it. It's only 3 tests. On the open market, by the way, it costs about $450 to do this. I think where I went to dinner the other night, that was the average check for 3 people. And of course, you can use this as an opportunity for smoking cessation. And these are some of the estimates. I'll probably get off the soapbox here. You know, the most conservative guy, which is one of our doctors in Sloan Kettering, Peter Bach, who many people think has led the fight against this. Even Peter says this will save over 4,000 lives a year. If you take the other end of the spectrum, it could be up to 80,000. The U.S., let's pick the middle one, 12,000 lives. 12,000 lives a year can be saved. It's just an amazing, amazing thing. And are we doing it? No. And sadly, I wasn't going to do this, but I will read the information on screening here. It still is full of things that you were never asked to do if you went for your colonoscopy, which I've had, or you've gone for your breast cancer screening. No one questions it when they present it to you. It's presented, you need this for your health, and here are the side effects. And here's some, a lot of us have screening programs. Actually, Mount Sinai, the group there has been a real leader. We have one too, but others do. Moving on. Let's talk about treating lung cancers. I think that one thing we have to get the word out is that treatments work. People kind of don't believe that. They just don't believe it. They say, oh, treatment is whatever. And if you read scientific articles, I just read one the other day, of course we know that lung cancer treatment isn't very good. Well, that's not correct. Surgery cures lung cancers. And by the way, there are probably about 30 or 40,000 people every single year cured of lung cancer through surgery. So about 25,000 people a year get ovarian cancer. More than that are cured of lung cancer every year. I mean, does anybody ever talk about that? And about the care of those people? let's talk about discrimination again. So who's had a family member that's had a bypass? So what happens after your dad or mom has the bypass? They're immediately put into a rehab program. And for 3 months, Medicare pays for an entire rehab program. What is the rehab program for somebody cured of lung cancer who has their lung removed? Zero. Nothing. Nothing. And their risk at the procedure and their risk to the postoperative period is clearly even higher. I mean, it's just a crazy, crazy world we live in. And it's actually those of us that have tried, and Carter, you may have tried to get somebody into pulmonary rehab after surgery. It's like impossible. It's absolutely impossible. But God love the 30 to 50,000 people that are cured every year. We need more of them. Radiation cures people too. It cures people whose cancer can't be cured by surgery because of a reason an operation would be safe. Also, it can cure people with more advanced forms of cancer when you combine it with chemotherapy. And I think the chemo with the radiation is something that can add to cure, that can add to the chance of cure, and also when you add it to surgery. When Burkle told me something very nice. I gave a talk, forgive me about talking about myself again. I gave a talk at the cancer meeting, and it was called "Why Chemo is Here to Stay." Yeah, they scheduled that talk an hour before the 5-day meeting ended, where most people, Carter, you were probably back home already taking care of your kids. But everybody gets chemo. And please don't remember that fact that people are cured, and I believe we saw one today, by the use of chemotherapy with surgery. Chemo lengthens life, and that all of our treatments improve the side effects, the symptoms that are caused by cancer, particularly pain, cough, and breathing problems. So how did this happen? And I want to talk about research for a little bit here. And there isn't one thing that makes the treatment of lung cancer more effective or better. It's a lot of things happening together and in concert, and I want to tell that story a little bit. So everybody's looking for ways to try to do a better job, and one of them is to try to figure out what makes a cancer cell tick. And they have this little list of things that make your cancer cells tick. It's called the hallmarks of cancer. I'll skip through that. So years ago, it was discovered that people that have lung cancers, when you do a test of those cancer cells, you find this protein called EGFR. And it's a standard test that can be done in any pathology department. So somebody said, well, wait a minute. Because we find this in all lung cancer cells, and we really don't find it too often in normal cells, or at least we don't find it in that amount, it obviously has something to do with lung cancer. So let's come up with medicines that can block the effects of this EGFR protein and the EGFR receptor. So the idea here was that you find this protein, it's there, you block its effect, and lung cancer is going to die. And the lung cancer will die or be attacked in a more effective way than other forms of cancer treatment, but also it'll kind of spare normal cells because normal cells don't really depend on it as much. So some drugs were developed to do this, and this is one drug called gefitinib, Iressa. It's not actually available in the U.S. right now, but it's the first drug that we had. Drugs are the ones, erlotinib or Tarceva. There's a drug, afatinib, Gilotrif, similar classes of drugs. And this is a very famous X-ray. This is famous for a couple reasons. I mean, this speaks to stereotyping. A person, this wasn't my patient, it was one of my colleagues, came to MSK with that X-ray on the far left. And generally, white is not good. The lung is supposed to be black. White is not good. So the doctor there said that there wasn't anything that could be done, you know, and basically told the patient that the treatment had been exhausted for her. But she came to MSK, and we recommended this medicine. And lo and behold, 5 days later, all those white cloudy things had largely disappeared. So, by the way, more importantly, that this person wasn't using oxygen anymore. She stopped taking Percocet because she was so short of breath. You know, for her, it was a personal, huge turnaround. Doctors saying this, we have some doctors. What did the doctors say? The doctor said, you couldn't possibly have treated this cancer. You treated an infection with this drug. Of course, the drug is a treated infection. Doctors couldn't believe that this person in 5 days could be better. They just couldn't believe it. They wouldn't accept it. And by the way, when the first x-rays like this were presented to the pharmaceutical company developing this, they refused to believe it. They sent a group of doctors to our hospital to look at the x-rays. They thought we were lying. Again, to the point of the stigma. They couldn't even believe somebody's lung cancer could shrink in a dramatic way in a few days. That's where medical was. And this isn't that long ago. This is just 12 years ago. So this is a famous x-ray for a number of reasons. But you know, this person did just great and things got better. But the story was complicated though. And this is where the science got into it. We saw those dramatic changes, not in everybody that had that protein on their cancer cells, but only in about 1 in 10 people. And again, the negative people said, you see, helps 1 in 10. It's just another crummy drug, crummy treatment for lung cancer. And then after a couple years, the tumors started growing again, too. So that was the other negative thing that people quickly brought up. So what happened here? Well, people said, well, wait a minute, there's something here. And folks tried to figure it out. So the first group of doctors were ones that made those observations and said, look at this x-ray. What happened to this person? And said, we're going to give you this person's tumor cells. Help us figure out what was it in this person's tumor that gave that dramatic effect. And these people in between here, between the clinical and the basic, are so-called translational scientists. They're the ones that took the clinical observation and the specimens and went back to the laboratory and discovered this. Basic people, too, knew about biologic processes. So they knew that that drug did one very specific thing. It turned off a specific enzyme and really didn't do anything else. So they figured out that if this drug turned off this enzyme, then what causes that enzyme to be turned on? And one of the things that they knew did that is when the gene that makes that enzyme protein gets mutated or damaged, then this enzyme gets turned on. So they thought up that there would be a mutated gene responsible for all this. That was the cause of the extra protein and the sensitivity in those patients. And the clinical and translational sciences gave them the specimens from those people that had those dramatic benefits. So the two guys that kind of thought up this gene thing are here. They're Dr. Varmus, you may know, he's now the head of the National Cancer Institute. But they won a Nobel Prize for this. But just to tell you how this works, they were studying a disease that was originally found in chickens and was in a kind of sarcoma. And by the way, these oncogenes are not invaders, they're not infections. We all carry these genes, but our EGFR gene is not mutated, and the other genes that can cause that. And these guys made that discovery. These are our own genes that get damaged by mutation. So very few things can do this kind of thing, and this is a slide actually from Dr. Varmus. So he had created a mouse that had a cancer-causing gene in it, and he had a way of turning it on and off. He could like flick a switch. And that's what he did here in this mouse. This is a mouse MRI. And again, white is not good. It's stuff. And when it turns black again, that means the cancer's gone. And he turned this gene on and off. And Varmus saw this x-ray. And he said, damn it, it's the same thing. There's a gene that we just turned off. And what gene, it's a drug that does EGFR. The EGFR gene should be looked at. And sure enough, when they got a specimen from this patient, they found a mutation in the EGFR gene. And this was the start of that story. The story, interesting, was played out, just to tell how crazy medicine is, up at Dana-Farber and Mass General Hospital. 3 separate teams. None of us had anything to do with each other, by the way. None of us collaborated at all on this. But we all discovered it within a few weeks of each other. So how did this happen? And I'll talk more about the possibilities that this opened up. But it wasn't one person. It was a lot of people. It was a lot of people. And people just trying to put their heads together on doing this, and that's how it happened. So what are the consequences of all this? Well, one of them, you've probably heard me saying this already. You think my slides are wrong. It's not lung cancer. It doesn't exist. It's lung cancers. It always was. You see two people with this illness, different things happen. Drug X works really well in one person, it doesn't in the other, different spectrum of side effects. It's always been a different disease. It's just that we haven't exactly kind of figured it out. And I think this is a really, really important discovery. And this isn't just for lung cancers, it's for really all kinds of cancers. They're all separate. I'll skip through that. So the other thing we've been able to do now, and this is for all lung cancers, is we've created these pie charts. And we look for all these genetic changes that identify specific kinds of lung cancer. There are other ways to identify lung cancer, don't get me wrong. But this is one way of doing it. Now, the most common mutation is this one in KRAS. And it's probably the most common mutation, not just in lung cancers, but in all solid tumors. But then we found all these other ones. And this is all lung cancers put together. So I think the important point of this is that these genetic changes that help define the illness in these tumor cells are present in about 2/3 of people. And this is all lung cancers. This is squamous lung cancers. This is small cell lung cancer. This isn't just the adenocarcinoma. So I think it's it's a good way to go because it points to specific treatments for specific patients. And this is an example of a group that I was involved with for the that looked at the adenocarcinomas, and this was just reported last month in a medical journal. Again, forgive the doctor stuff here, but what these are longevity curves. And the longevity of the different groups of patients is determined by which one of these genetic changes was found in their cancer. And I show you this to say that each of these things imparts a specific course to the illness. People with one of these specific kinds of mutations have one course, people with others have another. And it also, though, you know when you find a ALK rearrangement, you know that those cancer cells are dependent on this ALK thing. They call it oncogene addiction. Oncogene addiction. That was a term actually coined up at Columbia. And if you take away that addicting oncogene, those cancer cells die. So it points you to a way of treating. So a blessed thing that has happened is that there are a lot of drugs approved for these various oncogene drivers, not necessarily approved in lung cancer. And already in the lung cancer guidelines, we have a list of all the different oncogenes that can drive a lung cancer and all the available drugs that can be used to fight it. So I'll point on BRAF. BRAF is another oncogene. It's mainly been talked about in people with malignant melanoma, the serious skin cancer. And there are 2 FDA-approved drugs for people with melanoma that have damage to this oncogene, the BRAF oncogene. But when we find one of these BRAF mutations in a person with lung cancer, we can use those same drugs. And here's an example. This is a pen mightier than the sword example. This is a script I actually wrote for a really lovely lady. And I just wrote for this vemurafenib. And I wrote on here which mutation she had. And it got paid for. So all this stuff is, is it FDA approved and all this kind of stuff. Well, on the open market, this script got filled in like a day, by the way. And lo and behold, remember, the white is not good, the black is good. This woman's scan got a lot whiter. She did a lot better and accomplished a hell of a lot of things that were very important to her. But the power of this is once you find this genetic damage, there's drugs out there that can work. And there's many of them. There's not just ones that are already approved for lung cancer. And there's a lot of talk about this now. They call it N of 1, personalized medicine, all these talk. And I'll show you some examples of how we're trying to take that forward. So we and a lot of other hospitals started looking at lung cancers and then routinely doing this genotyping up front. And lo and behold, we found these genetic changes in lung cancers in about 2/3 of the cases. And there's been a huge technological explosion in doing this kind of genetic testing. It used to be that to do one of these genetic tests cost about $1,500 just to do one. You can now do hundreds of them for $1,000 or $2,000. So the cost has come down tremendously. So here's a company that does this. So they do 230 genes, and a comparable cost to doing any 2 genes. And this is what's happened over the last few years. So with this really cool fancy machine has now been replaced by an even cooler fancy machine. Again, forgive the self-serving nature of this, but Sloan Kettering just licensed this technology to Quest. So I bet at least some of you on the day in today walked by a doctor's office and saw that little Quest box sitting out there. So within a matter of weeks, your doctor can throw this sample in that Quest box and send it to Quest. So this is not, a fancy thing. This is something that every one of your doctors can do. And again, it does 340 genes. And one thing it's also done is it has, I showed you that list before, the drugs that we have when we find the various genes. But also, it's really accelerated research, too. So think about it. I want to test a new drug for MET amplification in lung cancers. Well, they happen in less than 1% of lung cancers. So how would I go about finding that? I would have to test hundreds of people to find those specimens. But now when you do this testing, this so-called multiplex testing, it's tested for everything all at once. It's, again, those of you that have been in the healthcare system, it's like a CBC. I mean, you cannot get a white blood cell count number without getting a platelet count number or a hemoglobin number. It's not possible. It's a multiplex test. That's how we do it. It's efficient. It works really well. Same thing here. And what this also has done is it points the way to research. And this has really opened it up. But just to do this now, by the way, it's made it a lot more complicated. We have 18 studies just for these molecularly targeted things. And some of them only affect 50% of patients. So let's take the stigma again. They said, gee, this EGFR story is great. There's a few people out there. Everything's fine. You help those people, but what of it? Well, interesting. Just right after that, if I point this up here, 2007, this is a group of Japanese investigators that found another one of these things. This is the ALK rearrangement. And it's turned out there was a drug that was being developed for MET, M-E-T, another one of these things, that happened to also potently inhibit this ALK thing. This drug is now called crizotinib. And in a very early trial, suddenly these people came in. And we doctors love these so-called waterfall plots. Each bar represents the degree of shrinkage an individual patient has. And you see on the far left what happens with the people with the EGFR mutations, that their cancers very uniformly shrink. The ones with ALK, the same way. And going from 2007, where a bunch of scientists in Japan found this thing in that very obscure scientific journal, which admittedly I did not read. Here on August 26, 2011, the FDA approved this. And by the way, they approved it based on the experience in just 256 people. Why? Because it worked. And the FDA, I'll say God love them. In this case, they did a really good job. They fast-tracked everything. And why? Because it really worked. So it didn't happen once, it didn't happen twice. So what's happened in the treatment of lung cancers? Well, already now, this is the, this is the wrong one. I'm sorry, this is the wrong. Already in the NCCN guidelines, this mutation testing is part of care. This is unfortunately way out of date. Since those discoveries I showed you before, 4 more of these things have been discovered in lung cancer. Something called ROS1, a company called RET, more HER2 mutations, and also this last one, the NTRK. The beautiful thing about these is there's already a drug approved for all those. ROS can be treated with crizotinib. RET can be treated with cabozantinib or vindetinib, drugs that are approved now for thyroid cancer. The HER2 drugs, the HER2 mutations can be treated with drugs for breast cancer, and the NTRK can also be treated with a ROS kinase inhibitor. So when you find these things, You can find them in these multiplex tests, and there are drugs out there that we can give to patients. And again, there's already been a bunch of scientific reports for the ROS1 and RET that people have very good shrinkages with those two. So what we're doing now is we're moving from the adenocarcinomas, where we started, to the squamous cell and the small cell cancers, and we're finding these genetic markers there, and they're basing therapy based on that. And I do have an updated NCCN slide here. And what is recommended now in the standard guidelines is that you do this multiplex testing at the time of diagnosis and use that information for the doctor. The other thing that was important here is this is not a science experiment. We are testing the specimens of people with lung cancers to find these drivers, and we tell the doctor. And we don't know exactly what to do with everyone, but we give the information to the doctor to make the best decisions for that patient. Immunotherapy. We have long looked for ways of getting our immune system revved up. It's our line of defense, maybe our first line of defense, and it's something we've tried to do now for over 100 years, and frankly, we just haven't been very good at it. Very few drugs have been approved based on their ability to rev up the immune system. But I'm showing you here a long list of unpronounceable names and numbers to show you the degree of activity of pharmaceutical companies in lung cancers. These are all trials in lung cancers, testing drugs modulating various activities of the immune system. One thing the cancer cells do is they tell the immune system which should kill them not to kill them. And we've been trying very hard to understand what the basis of those signals are and to take them away. And these drugs actually do that. They take away the brakes the cancer cells have been putting on the immune system. And all these drugs are in far advanced trials, and some of them are already in phase 3 trials, which is the one step before they're going to be approved. And they all work to some extent. This is a little different kind of a graph. These are patients that had metastatic lung cancer discovered and didn't get a standard chemotherapy, instead just got this immune therapy. And in this case, going down is good. 0 means no change. Going down means that the cancer is shrinking. And you see the vast majority of cases here, the cancer shrinks. Interesting, because it's an immune therapy, sometimes it grows before it shrinks. Sometimes it takes longer than a chemotherapy, and these are the things we're learning. But these drugs actually do work, and based on that last slide, there's a huge amount of development in this. So I talked about these sequencers, and there's a whole bunch of them, more and more capability. You can now do that 300-plus gene testing in one day. What takes time, by the way, and many of you that have dealt with the healthcare system, is getting the slides from the hospital where your biopsy was, getting them recut and sent to the hospital that you're now being cared for, and then getting them processed there. That's the biggest time sink now. Of course, we need to find a way to get around that. These are all those genes. But these are all those genes I showed you before. This is what your doctor gets, by the way. Now, I joked that when I went to medical school, we did not have DNA. We actually did. But we didn't have molecular biology. There was no such thing. And I'm a young man, not that young. But this is the report that crosses your doctor's desk. And I don't know if any of you that have patient portals, does this ever cross your patient portal? You get this? Oh my God. I'm not sure what to do. And here I've highlighted, this is the meat of it. You tell me what that means. So this report is sitting on Cardi's desk today. There's some variation on it. And she has to figure out what does that mean, for Mrs. Gonzalez. And it's not easy. Luckily, I call up the smartest guy in the room, one of our molecular pathologists, and I say, what does this mean? What do I have to do on this? What would be a good drug for her? So this is an issue that we have to face on a couple levels. One is to explain it to you, the people with the illness that need to know this information and factor it into how it fits into their fight. And also from the doctor's standpoint, how does this translate? all medical information is taking off. There's an exponential rise in medical information, and I'm unfortunately running out of time here. If I could have a minute or two more. So this is a little project I've been involved in. Anybody a Jeopardy fan? Yeah, okay. You may have remembered this show. These are the Jeopardy champions. That's Ken Jennings. I don't remember the other guy's name. All-time money winner and all-time, I won for like 80 days in a row or something like that. And they played a computer, and this computer was Watson. It's kind of interesting. You just say how these things work. You know, the question, of course, on Jeopardy, you give the answer. You give the question, and they give you the answer. Wow, how did that happen? So, but here's the question they answered. William Wilkinson's An Account of the Principalities of Wallachia and Moldavia inspired this author's most famous novel. So you could guess, what it might be. So think about figuring that out. They didn't ask you who wrote Dracula. They didn't ask you, what was Stoker's first name. They asked you that crazy question. And it's not easy to figure out. I never heard of, I don't think they're real places, right? There is a Moldavia. I don't know if there is a Wallachia. Maybe there is or not. But it's not easy to figure out what they were asking there. And that's what they designed this machine to do. What is it? It's a gigantic computer. It has what they call natural language processing, which means it can read natural language. It's kind of like Siri, if you want, but it can read text. You don't have to enter stuff. And lastly, it is what they call the next generation of computing, so-called cognitive computing. So it can learn. It learns by giving an answer. So when it answered that Bram Stoker question right, it then learned that the next time that question gets asked, that's the answer. It learned it. No one programmed it. The computer learned it. So folks felt that this could be developed in medicine. And I gave you an example already about those molecular pathology reports, but we are always analyzing data, and I'm about to get the hook here. And then occasionally we went to a computer, and then we gave the decision of what we thought was the right answer to the patient. We also had that thing up at the top there. I don't know any of the younger generation here. That's called a textbook. There's a generation of people that carried them. They went to large lecture halls. Didn't have to go to the gym because they carried textbooks. But as you know, people don't, the next generation of people do not use textbooks. They don't even know what they are. So the idea was to take all this crazy information and then have a computer help you analyze it, present it to you and the patient, and then the three of you together work things out. And that's the idea here. And this is kind of a prototype of what we're trying to do, where patient information goes into the system, medical information is there, and we tried to make the best treatment choices. We've tried very hard to have data about the patient's approach to the illness, issues that they have raised in their care, and also access to clinical trials, and of course providing medical evidence, and this is what we're working on. I'll skip through this. It took them 4 years to win Jeopardy. I'll put it to you, this is a lot tougher, a lot tougher. So it's going to take some time. But I'm convinced it's not an issue of if, it's an issue of when. And again, this is our team motto. You don't realize how hard this really is. This was the father of Jeopardy, Watson, by the way, who now works for a hedge fund here in Manhattan. So I want to close about survivorship. I already mentioned it's neglected. It needs not to be neglected. We need to just, number one, find out what are the needs of our survivors and then try to meet them. We know that the survivors have had tobacco exposure, their risk for other cancers. We have to deal with that, their risk for second lung cancers. And we've added survivorship now as part of NCCN guidelines, but there's just not enough attention paid to that. Maybe I'll end on this slide. I took this from a report that the American Lung Association had about stigma. And I'm the guy with the glass of water. We have to deal with what we have. So I picked only the information about what they think we can do. And these were a few things that they thought were important. And I've tried to do a few of them today. I think the first thing is we need to increase the awareness of the scope and severity of the disease and dispel myths. And again, I think the biggest myth is that the person with lung cancer was just out in front of the building smoking a cigarette. That is just not true, and that myth needs to be out. People have stopped or have never smoked in the first place. The second thing is to empower patients and caregivers to be more proactive. That guilt has flown down to them too. I've sadly heard people think that it was their fault. It is absolutely not their fault. These people were targeted, and you were targeted at your most vulnerable time, mainly like your 12th birthday, and that was the plan all along. They were after 12 and 13-year-olds, and I have to say our judgment was not great then. And we have to help our patients and families deal with this. We need to remind people about these treatments. And actually, this is probably a good thing because people are saying, you know, this works in people with lung cancers. It's going to work in other cancers as well. And I think that will give us some street cred, actually, with these people that don't think we've done anything. We need more money for research. The screening is really important. I mean, it's disturbing that there are people that are going to die of lung cancer this year that didn't have to die. All they needed was a CAT scan that cost $400, and we really need to make that happen. And we need better guidelines, and I think I've shown you some examples already of where we're doing that. So with that, I'll end. We've made tremendous strides. We have a long way to go, I do think there's always been reason for hope, but even more so now. And I think Dr. Smith's talk as well shows you that what I've been talking about the cancer-directed stuff, but it's only part of the equation, obviously. And all of the, I think the approaches in supportive care and palliative care are now more on the forefront than ever before. And I think what we're going to see is more and more of a melding of those two branches on the road. And hopefully as we go down one road, we'll get to the goal quicker. Thank you.
In our marketing, the way I see it, it's just starting all over again with the big tobacco companies doing that. I'm very concerned.
It's sort of complicated. I think the first thing is we really don't have, I think fact one, I think anything that leads you down the path to tobacco smoking is bad. So if there's any aspect of that is kind of a starter cigarette, then it's bad. So that's number one. Number two, nicotine replacement has been a really huge help for a lot of people trying to quit smoking. And we have that piece in there too. I mean, there have been people, and they've heard some of the comments, that it's really helped them do that. And it's more socially acceptable. I think the bottom line, though, is we probably have to fight it because I think it just makes smoking too easy. And things that have made smoking hard have been the most important thing for stopping it, so I think we have to do that. I don't think people really truly know the health risks. It is true, though, compared to putting a cigarette in your mouth, it's a lot safer. And those of us that have done that for many, many years, that's a lot safer behavior, but I think it's too risky. I don't know if other people want to comment on that.
Well, I think anything that comes out of the tobacco industry or that is promoted for commercial gain has to be suspect. And it's, as Yogi Berra says, déjà vu all over again. This is not the first time that the tobacco industry has tried to reinvent cigarettes. Probably won't be the last time. You have to be very, very suspicious and resistant.
I have a niece who's been smoking the e-cigarette for 2.5 years. She started smoking it as a way of quitting smoking. Now she finds she's smoking even more because it doesn't have an odor. So instead of running outside to have a cigarette, when her kid goes upstairs to take a shower, she takes a little hit on her e-cigarette. I think the e-cigarette gives you permission to smoke more, smoke wherever you want, because we're starting in New York City, though, they don't allow it in the parks. We have to initiate Clean Indoor Air Act, and all the policies that we've worked on for no smoking, we have to include the e-cigarette now. As the doctor said, if the tobacco company is involved, it has nicotine, which is very addictive. I think that's two red flags that we have to look at and stay away from.
I'm a nurse practitioner in Hartford and work primarily with COPD. But many of my COPD patients have tried, at the behest, unfortunately, of their pulmonologist, to try the e-cigarette to quit. And that disturbs me more than I can say, that that our physicians are saying it's okay to use them. The several people that have tried, and I have a neighbor across the street from me who is 37 years old, his kids were the ones that begged him to quit smoking. He quit, and then a couple of days later came back with an e-cigarette. He was smoking at least one cartridge a night, which was equivalent, they found, to 2 packs of cigarettes, the nicotine contained in that cartridge. There are something like 4,000 e-cigarette makers, and they come in multiple flavors that are definitely targeted at our kids. They come in bubblegum and peach flavors and strawberry and everything. So it's definitely a target at our kids. So it disturbs me terribly that anyone would use the e-cigarette as a smoking cessation tool.
Just a quick comment. Everyone here, I think, is very positive about things that are organic. Nicotine is registered as an organic pesticide.
Just to piggyback on what you said, do you find that where I live, I see a lot of young teenagers smoking the e-cigarette? Do you feel that it's more of a fashion statement now? It's becoming a fashion statement because even parties, it's like that's all they're doing now. Whether or not they used to smoke or smoke, it's a fashion thing. The other thing I wanted to ask, Dr. Chris, you mentioned that 84% of persons who are diagnosed with lung cancer have stopped smoking or has never stopped or has never smoked. Do you find that people who have stopped smoking end up with lung cancer as opposed to someone who continues smoking, never stopped smoking, but they end up getting something else other than lung cancer? I have a coworker. Her mom has cancer, breast cancer. Cancer runs in her family. She smoked religiously. Her husband passed away because of cancer, another form of cancer. But yet, we talked, she will not stop smoking because her fear is that if she stops smoking, she's going to get cancer.
Many of us have heard those sort of testimonials. Well, the truth is, stopping smoking cuts your risk of lung cancer, not because your lungs heal, but because you smoke your cigarette. So the truth is, anything you can do to cut down on smoking the cigarettes does help. And again, I'm sure there have been instances where people that have had stopped and then lung cancer was discovered shortly afterward. But I don't, those of you that smoke know that you have kind of constant health problems when you do smoke all the time. And very often, people, they stop smoking because their cough was worse. And the cough was worse because they had lung cancer. And then they say, well, I stopped smoking and now I have lung cancer. I mean, that has happened to a lot of people. But in general, every less cigarette you smoke is lowers your risk. And I think that's the main thing there. But what you say is absolutely true. People aren't going to stop. One thing is that people are horribly addicted. I'm not an addiction expert, but I'm told the two worst addictions are crack and nicotine because of this immediate high that people, it's very, very hard to break that habit when you get the immediate high you get from the nicotine of the cigarette or from crack. So it's very, very addicting. And frankly, we need better ways to help these people. It's really, really kind of sad how ineffective our treatments are for them.
I had a quick question. So I know that in melanoma, these PD-1 medications are like the new saviors for everything. In lung cancer, it's being studied. I think I saw in there it's phase 3. Do you guys believe that's going to be something that's going to be a mainstay of like initial therapy? Pretty much everybody's going to be put on these one day, you know, turning on the immune system, or is that something that's going to be kind of supplemental? If you failed everything else, this is kind of a last-ditch effort to see if we can get some benefit.
You know, there have probably been 1,000 people with lung cancer treated with this stuff, and there's no question that these medicines work. Like many cancer treatments, they don't work on everybody, but for a huge number of patients, they provide benefit where other treatments have not, and it's lasting and durable, and their lives are minimally messed up. So they're here to stay. I think what's going to happen is that these treatments are going to be combined is probably the wrong word, used with the other treatments that we have. Either at the beginning would be followed by a standard chemotherapy or radiation treatment, or given afterward. I think that's what's going to happen. The other thing that people have noticed is that standard chemotherapies modulate immune cells in a way that can make these drugs more effective. So I think what you're also going to see are people using available therapies. I'm sorry, I mentioned somebody earlier today. There was a paper about using interferon with commonly used for various kinds of cancers, using it with these immune therapies. So you would take interferon, kind of prime your immune cells, and then take these treatments. So I think that's going to happen. I think the challenge over the next 5 years is finding out, matching the right drug to the right patient, the right sequence, and the right parts of that sequence. But these things are very real. I don't think there's any doubt about that. But how it's going to play out, I think that they will be one of the standards of therapy 5 years from now. I'll go on
My name is Tina. I just wanted to, I'm a nurse practitioner at the VA, and lately the VA has gotten a lot of bad press in the media, unfortunately, but we do wonderful work. And I wanted to focus in on one thing that we're currently doing that I actively do is I'm a lung cancer screening coordinator. And the VA has put together, we have a large population of veterans that smoke. And the veterans will tell you that, you know, the military made me smoke. I started when I was a young kid. When I was in the VA, when I started, I was in Vietnam. They were in our MREs. The population of veterans who actively smoke is higher than the average population. It's about 34 to 37%. And then you tack on mental illness, it's even higher with the mental illness population. So the one thing that the VA has been doing, and I don't know in terms of what the general public knows, we're actually running a project, a national project on lung cancer screening. And it came out of the study of the trial, and 8 VA sites were selected, the Manhattan VA and the Brooklyn VA, where I work out of, and 8 other sites in total across the nation are piloting this project. So what we're doing is we're taking veterans who screen in, and the National Lung Cancer Screening Trial did 55 to 74. We screen in veterans 55 to 80. Same in terms of 30-pack-year history, quit within 15 years, and we're actually giving them the 3 CT scans, and it's also based on a copay, so or they don't even have to pay for the CT scan at all, and they're getting them. I'm finding as a coordinator and also as a tobacco treatment specialist, the difficulty is you find the veterans who have the nodules. Many of them actively have nodules where the guidelines are follow within 3 months, 6 months, 12 months. It all varies what the findings are. It's getting the veteran to want to come over and say, well, I just had this screening, I actively smoke, how can I then say, we can help you? Is this more of a sign to say, well, I have these nodules, maybe I should quit? Other ones just kind of say, thanks, but no thanks, I really enjoy smoking. It's good to know I have the nodules, I'll come back in a year and see if it gets any worse or if it stays the same. So it's a big challenge that I'm finding, and I'm happy to be a part of such a major event that they're taking part, where they want to expand it actually nationally. And it's a venture with the DOD, so the DOD has been doing this probably 2 years prior, the Department of Defense, and they're active in it. It's just getting people to say, yes, I had the screening, I have these nodules now, but how can I get to want to quit the smoking? And it's very difficult.
Thanks, Tina. Thank you. Is smoking cessation part of the screening program?
It is.
Okay, there have been studies that have shown that of people who've had screenings with findings, they're more likely to undergo smoking cessation and to stay quit. So I would just say, I echo what Dr. Chris said about it being an addiction. The epidemiological studies show that smoking is the most addictive, more than heroin and cocaine. So I think you just have to keep trying.
We're actively trying, and we have so many resources for veterans, and I will hope that Medicare, it was just some news recently that came out that Medicare is not sure about approving this. So it's out by the private insurer, but if Medicare takes a foothold and decides that they're going to do this because their population is 65 and older, and that's 70, most of them are 70, they're saying that they may not actually approve this because of the health benefit, the risk related to it, unfortunately. The great thing is that we're actively doing this to help our veterans because it's such a prevalent issue. Thank you, everybody.
Well, just a comment on the risk, though. If you're a lifelong happy-day smoker and you're still smoking at age 65, your chance of getting lung cancer in the next 10 years is 10%. Absolutely huge. There is no other, group to screen as any other common cancer. There's nothing approaching that. So it's such a potent cause in people that continue to smoke at that. And by the way, I applaud your stretching it out to 80. You know, that 74 was again based on I'll say an age stigma. Because the reason you're cured with screening is you have surgery to take out a tiny nodule. People assume that if you're 75, you couldn't have surgery, which is absolutely incorrect. Maybe it was 15 years ago, but not now.
The American Thoracic Society recently, we heard about the efforts of the VA. I think, in addition to the information that we already have, the information that's going to come out of that study is going to, it's unequivocal now, but, you have to keep beating someone over the head to have them release the money. So the more information we have, the better it will be.
And of the 140, I believe about close to 90 we're tracking with nodules. So the percentage is very high with the nodules that are being found. And they range from a minimum of 4 to 8, or if even larger, that they're finding. So all the radiologists are trained in this, and the just findings and how we should go about following the procedures for it.
I think, again, giving a plug for Mount Sinai, Dr. Henschke and Dr. Yankelevich there have really been international leaders in how to interpret these scans. I mean, it's a learned phenomenon, and there's a lot of information out there about how to do that. And your colleagues there are really the leaders, and they publish quite a bit about that. So this came up at our place too. We do 50,000 CAT scans a year.
Wow.
Of the chest. Wow. So I bet Sinai is not it's tens of thousands.
I haven't checked the numbers, but it's got to be a lot.
Yeah. So people know, and a lot of people are over the age of 70. So radiologists can deal with this, and again, it's a learning curve. But there's a lot of pioneers. I think have already led the way here, and you can do it in an efficient and safe way.
Yeah, I was just going to add to what Dr. Chris said about the ILCAT group, which is the group that Claudia Henschke and Yankelevich lead at Sinai, which, controversy, but you showed the New England Journal article in 2006 that they published first before the National Lung Cancer Screening Trial. But they have done lots of work within the last several years looking at specifically the size of lesions, what they look like, the amount of the solid component versus ground glass component, and followed people out for up to a decade, if not a little bit more, in terms of what the natural history is of those lesions in both smokers and never smokers. So we do have lots of information on what the best way is to follow those folks and what their risks are.
Hi. I actually am very grateful to the early detection scan because Dr. Henschke, I met her personally, and she said you know, go get the scan. I quit 30 years ago. She goes, go ahead, go get the scan. I did, and they found small cell lung cancer. And the question I have about that is that my tumor's now 99.9% gone. I'm really so incredibly grateful. But here's the question. There's a gap between, I was told never to go on the internet, and I think that's because there isn't just enough data that, I mean, it was just like what I read was horrific. But then they said, my oncologists and radiologists were saying, no, you can make it. And I still couldn't believe that because what I had read and heard from people was that I was a goner. So is there a place where you can get more up to speed using the internet so that people like me don't have that horrible months and months of agony thinking we're just going to die in a few months, when I actually did hope, there was hope for me. So I guess that's my question, is how to get the media more involved.
My son went on the web, and he said, Mom, you're going to die in 5 years. And I said, I wouldn't give you the satisfaction. And I said, do not believe everything. You know, everybody's individual, and there's miracles. I believe in miracles. And because they said that, and I kept saying, it's old information. But when I was getting chemo, I was looking on the web because I was having such a difficult time with it. And my oncologist said, Denise, you just have to stop. You know, we're doing the right treatment for you. So I don't go on the web. I don't want to know. I mean, I'm feeling good and I'm feeling healthy, and I have hope that I'm going to continue this way. So
I do too, but I'm really
it's like I don't read the obituaries. I don't want to know.
Personally, I'm now moved through that, and you and I spoke, and I understand that. But I'm talking about the moment of diagnosis, when there's this gap between what your doctor might be saying is possible and then what you're reading and hearing. And it's really a media
when
question.
When I was first diagnosed?
Huh? No.
I didn't go on the web. I didn't want to know because I already felt that everything was going to be all right. And that's the way I handled it. I just...
You know what I'm hearing is, like you said, from the moment that I was diagnosed. That moment is already gone. You just said that you're 99%. Just let me finish. The way I deal with it, I don't want to know a lot of stuff either. But when something comes up, then I'll address it. I don't go looking for it. My friend went on the internet for me. He did that. He did all the research on what doctors to go to, what hospital, yada, yada, yada. Personally, when something comes up, when I see Dr. Smith, I'll say something at that point. I already know what my problem is. I have lung cancer. It's stage 4. This is what we're doing. So I don't have to continue to look for something else because I already know what it is. That's how I approach it. I'm not saying it's the right way. I'm just saying that's how I do it. Because it lessens the anxiety, because I think anxiety and worry, it does nothing for me to know what may happen, what could happen. It happened for 10 people over here, 400 people over here. You know what my neighbor said to me that was really clear? My neighbor died of cancer. So I went to her, I said, you know what? Robert came back to get me, and I told her I had lung cancer. She said, his name was Robert and yours is died. And that was very clear. That what happened to him has nothing to do with you. And that's how I have to approach it. I can't approach it because you had it and something happened to you. I can't deal with that type of stuff. You know, I have to look beyond that and say, well, somebody stepped on this thing and they fell. I stepped on it and nothing happened. True.
I think just a couple other comments. I think the first is there's a lag time as to what appears in the on the web or definitely in the textbook. A medical textbook's 2 years out of date at least. So if you read something in a book saying that that's what happened 2 years ago, and there's a lag time on the internet too. I mean, we deal with this all the time in this Watson project. How quickly do you get something out there? No matter how quickly you do that. A lot of the stuff out there is not good. A lot of us have worked with a group with the American Society of Clinical Oncology. They do have a pretty good website, cancer.net. It's about as well annotated by authoritative doctors, not influenced by individual centers. And I think it's pretty good, cancer.net. I recommend that as a starting place. I think the other problem, though, is our institutions are all out there too, saying this and that, and it's sometimes hard to tell what's the right answer there. But I would know about the lag time, and also I'd start with the cancer.net. But for small cell, by the way, people kind of gave up on it. And blessedly, there's a resurgence right now. Congress chose a couple of cancers as so-called recalcitrant cancers, and they have a bunch of panels of scientists and physicians working on a couple of different cancers, and one of them is small cell. And there's a report coming out, there's real energy and a lot more research right now, so hopefully that is coming back on people's screens. One thing that's happened in medicine, and we talked about the stigma, a lot of docs have stayed out of lung cancer, thinking it's not, the doctors thought it was hopeless. And also from a money standpoint, I think that there's in some of the handouts today it showed, there's $10,000 spent on breast cancer and one on lung. So if I'm a young doctor looking for research money, where am I going to go? And a lot of that happened. I think that's changing, but you need to know it's out there. But I would be very hopeful that a lot of starts going to be.
And I have a question for those of you who have screening programs. I know that some of the recommendations are for 3 years. At Stony Brook, we're basically screening until you age out. So as long as you meet criteria. And I'm wondering how you, for me, I don't know that I'd be able to give reassurance to somebody who has 3 years of stability when, as Dr. Chris pointed out, let's say at 58 years old, you have 3 years of stability, when we know at 65, especially if you're still smoking, you have a higher risk. I'm sure that the recommendations are still going to evolve over the next few years, but what are your thoughts on 3 years and stopping versus age out?
Well, I just don't think we have the data at this point to answer that question completely, but intuitively, if you are a serious smoker or a past serious smoker and you have a certain risk at whatever age, 50 or 58 or 60 or 65, that risk will continue because we pick up lung cancers all the way up until age 90. So it does make sense to continue screening, but how that's going to play out with the regulatory agencies and with Medicare and all this, that's a work in progress.
At Sinai, we are in a very interesting position because we serve the Upper East Side, and then we serve our East Harlem and Spanish Harlem community, and so the inequality and disparity abound. But for those folks who can pay, whose insurance is not yet covering it, they continue to pay every year. And at Sinai, it's $300. I'll just tell you, my mom is 68. At the height of her smoking, she smoked 3 packs a day, which I can't imagine. I don't think she ever didn't have a cigarette in her mouth. But she quit 11 years ago, and she did screening for the first time this year. Thankfully, it was okay. She has Medicare, and Medicare did cover it. So that's what we do realistically at Sinai.
I think as a community we have to be a little careful here because we're under the microscope. It seems to me that the prize is the 8 million. Yeah. I would really want to be careful that we don't neglect those 8 million people where really nobody can quibble they should be screened. We've got to get those 8 million screened. On a personal note, every cigarette increases your risk of lung cancer. So if you're still, whatever your risk was when you started screening, if you're still smoking, it's higher. Also, the cutoff at age 74, that was based on the time where you couldn't do surgery in 74-year-olds. That time is over. So I think that 74, to me, is fluid.
people that continue smoking, I think they should be continually screened, and that's personal. But again, we got to keep our eye on the prize. We got to screen those 8 million. And we heard already people don't want to pay for that. I think they're going to interpret our stretching and screening, by the way, as being, we're not good stewards. We're really under the microscope now, whereas no other diseases. That we need to show that we are good stewards, we're totally evidence-based, and go after that 8 million.
Hi, my name is Tina. I was diagnosed with Mount Sinai and now I'm in lung impediment. My curiosity is, what are your thoughts and concerns about young women, non-smokers, that are being diagnosed in the prime of their life? And I've been told it's just bad luck. And also, what can be done for the targeted medicines where they can have longer lasting effects on women like me that have young children and want to be there a long time?
We want you to be here a long time. So obviously, the one thing we've learned in cancers over the years is it's really complex, and there isn't an easy answer. And it's some unbelievable mix of who you are and where you live that brought this thing on. Just the mutation stories, for example, why do women that didn't smoke in Japan have more mutations than those that didn't smoke in New York City? We don't really know that. But part of it is your own individual genetic makeup, but it's more complicated than that. The other thing that's happened, though, is this understanding of biology really helps us to take the next step. And there's a story now, I don't know if this applies to you or not, with the ALK rearrangements. I showed you that it just took 4 years from a discovery to getting a drug approved. Well, about 6 weeks ago, a second drug was approved, specifically for those people where the first drug stopped working. So when the scientists know why the drug stops working, they can find another drug. And I think that's probably the most hopeful thing I can pass along today. That because we know what causes it, and we know what happens when it escapes the control of the first drug, it points to what second drug might work. And it has worked. I mean, for the people with ALK that didn't have a choice 2 months ago, they all now have a choice. And I see that happening over and over. I would add on the immune treatments too, because right now they seem to be in parallel to this. So whatever benefit you can get out of the targeted therapies or the standard chemos, that this immune treatment, if your cancer cells are wired the right way, is going to be in addition to that. That's the story we've seen most now. People that have gotten all they can out of the standard drugs and but one thing that we have learned in the last years is how complicated it is and how kind of humble we have to be, but keep plugging away at it, because it is very complicated. There are no quick answers or easy answers.
I just wanted to make a quick comment regarding the website and the access online. Only because, so I myself am a physician, I'm in dermatology, so don't want to step on anybody's toes up front, but my mother was diagnosed with lung cancer, so regardless of how many years of studying and training and whatever it was, I went right to the internet. First second I found out, I was on my phone on my way home trying to figure out what's going on. So I think the biggest thing I learned, from personal experience is it's meant to be a supplement, but you can't really take everything you see on there so literally. I mean, for me, the message boards were very helpful. I think it was like inspire.com or whatever. I spent 4.5, 5 hours on there the first day. And you learn a lot about side effects and people going to very simply, like just how to talk, how to talk to people about this, like what are you going to expect, things like that. All the outcomes and 5-year survival rates and 1-year survival, all that stuff. I mean, as it was mentioned, you don't know how accurate it is. It's not worth hanging on every single word. But there is, I think, and this is something I was guilty of. I used to kind of roll my eyes when people would bring in, oh, I saw this on the internet, I think I have this syndrome or this whatever, and I tell them, like, look, there's maybe 1 or 2 people in the world who've ever had this syndrome, like, it's okay. No, you don't have that. But I think, it's important to, utilize the communication tools we have to get perspective. You can't replace the unbelievable people that are sitting up here in front of all of us right now, but I think it's, there should be probably more about like a almost kind of like a guidebook the second you get on, and you know, this is like stop. This is what we have right now, and this is the next few steps. You know, outside of that, I think the best resource we have is just talking to other people who have similar conditions, and then again, that's what we did. And I think it kind of eased some of our big concerns, and then you approach everything else as you need to. But simple things like medication side effects. Like, yeah, I mean, again, myself, I don't tell people the 20th and 21st most common side effect, but how am I supposed to know that, you know, if they're going to get it or not? So maybe, you know, that's something lacking on my end. But I think a lot of these big-time medications that everybody take, you know, like, yeah, you have a little bit of this or a little bit of that. Just check and see if anybody had something similar. So, again, there's no way of replacing the knowledge, and nor should you try to. But I think there is a role for that, you know, to investigate a little bit. You know, take some of the things with a grain of salt, but again, just try to, you know, whatever can ease your fear and your concerns, that is helpful. So I mean, that's something, and I'm part of the Sinai Health System as well. So in our department in dermatology, we for melanoma patients, we definitely we provide them the internet. We tell them go on the message boards, read, see what people are going through, side effects, and then ask us any questions you might have. So again, it's a very, you know, slippery slope, and I certainly acknowledge that. I'm sure everybody up here has had experiences, but you know, it's one of those things where, you know, take everything with a grain of salt. But if you find some benefit, you know, by all means.
Socrates never wrote any of his never wrote up any of his dialogues. He would have never been promoted in any modern institution. He left all the heavy lifting to his disciple Plato, but he did answer the question of why he did not write anything, and the reason was that when you write something, you can't ask questions about it. There's nobody there to answer the questions that the writing raises.
I urge folks in that information-seeking moment to try to let others help you with that too, particularly the person who chose to lead your team and all the people that work with that person. I think listening to your story today, Dorothea, about the way you really put your trust, I think, in the Lord and in that woman next to you. And so many of the questions you have, you would bring to her and maybe to the Lord too. But I think that's very, very helpful. I don't think you can take on that it's all your responsibility. You have to look to those people that are your support to shoulder that with you, and that goes with information as well.
I'm a firm believer in the support groups that the two that I do attend, one up at Sloan and one at NYU, which is where I'm at. There were so many things I was going to say now, they're all out of my head right now. One of the things that, for me, you know, like talking with you earlier about, you know, turning it over, for me, you know, there's a lot of stuff, and there's a four little word for stuff about cancer out there kind of thing, you know, where you're a smoker and all this kind of stuff. And I just take all that stuff and I just turn it over, put it up on the shelf, and let it sit up there and do what I have to do as a cancer patient. And in the beginning, I remember when I had my second opinion at NYU, and I was talking with the oncologist, and he said, well, what do you think? And I said, well, let me think about it. And I suddenly sat there thinking that, you know, if I Google it, I'm going to Google myself off of my balcony. Yeah. Literally. I will go crazy with this and just end it all. So I said, you're the doctor. You tell me. And he said, well, we plan to do this, this, and this. My two words for him, to him were, let's go. You know, and he remembered that 6 months later after the PET scan. He said, do you remember our first conversation? I said, no. He said, let's go. So I have complete faith in the man. I'm very happy there. But I do believe that, you know, the support group is a great system, and I'm happy about that. Is there a better chance of getting pulmonary? I have also recently been diagnosed with COPD as well, mild case. Is it my better chances of getting a pulmonary rehab from the COPD or the lung cancer? Does anybody have a? Can I play that card?
I don't think it really matters.
Okay.
You just have to have somebody who refers you.
Okay.
For it.
Lung cancer is like a terrorist lying in wait, waiting to attack either physically or mentally. And that's a big part of it, I think, of lung cancer. You know, when I finished treatment and I had my first PET scan and it came through, you know, NED, I was, all right, now what? You know, I'm in sort of this limbo area kind of thing. And now it's 9 months later, I've just been diagnosed with increase in the size of a node in my lung, and scheduled for an ablation treatment next month, which isn't fast enough for me, but where was I going with that? But I have to be very careful about that, that worry. So my way of dealing with the cancer, I don't know how many of you are cancer patients here, but if you're in a situation where you can recommend to them, just turn it over. And, again, there's another organization, and their motto is lung cancer, find it, treat it, live. And that's how I do it, kind of thing, I've had the treatments. I'm able to live right now. Fortunately, for me, if this treatment goes through well, you might find me in Finland at the end of August. That's the plan. If not, so be it. It's not for me to say, but that's how I look at it. I'm always looking toward the future and being positive about it, and I think that's very important for a patient to have. Thank you.
I have a question for Dr. Smith. I work primarily, as I said before, with COPD patients, but when I approach them, I actually do a class during pulmonary rehab on advanced directives, and we talk about the importance of this. Now, I've been doing this class for 25 years or more, and right down the line, a third of them said, of course I have an advanced directive, I don't want to bother my family, of course I have one. A third say, oh, I never thought about it before, the doctors never mentioned it, maybe I should have one. And a third stick their head in the sand. So what do you do to address the importance of advanced directives for someone with a serious illness when they stick their head in the sand?
So denial is a beautiful thing because it works. I will start with that. It is a defense mechanism because it works. I think short of that, it sounds like you're doing it. You're counseling them. There is the, yes, I want things to continue to go well. I hope things continue to go well. Let's talk about if things don't go well and what that might look like for you and what are the things that are important for you. What are you hoping for as a way to get at it? There is also a really great website, and I'm totally blanking on the name of the website now. It will come to me, but Rebecca Sidore, who is at UCSF, is a Jerry palliative medicine doc, developed this website focused specifically on older populations, but it is a way to create your advanced directives, and it's all online. And it's a website that's very user-friendly. It's geared towards a 6th grade health literacy level, and it walks you through every step about, do you have an illness? What are you hoping for? What do you want to achieve? And you end up with an advanced directive by the time you're done. More to think about this way. I think it's prepare. I don't know if you give me your card, I can send you the link, because I can't think of it right now. But that's another avenue that you could pursue.
Yeah, I was involved in a hospital project to get people to complete the form for the designated surrogate. Mm-hmm. And it was a group of surgical patients and my population of people with lung cancer. The surgeons had a 90% completion rate. They would say to the person, what does the president do when he has surgery? He designates somebody to speak for them. Please designate somebody. I have a 30%. And it's because no matter how I tried to present it in the same way the surgeon would, who do you want to speak for you if you can't speak for yourself? It got interpreted in a horribly different way. Yeah. And then people were very uncomfortable making a decision, just to share that with you. I don't know if some of the patients may want to comment on it. But hearing it from your oncologist, it was totally different than hearing from your oncologic surgeon, actually, who's about to operate on you and perform a very serious surgery. It was very different, so be careful. I think the key thing, too, is tell your family what you want. That is the main thing. It's what you deserve or what you want, and then secondly, it just takes the pressure off them. What they don't have to guess what you want. And actually, New York State has that thing, that MOLS thing, yes. That it's called, which is exactly that, right? It's all about you saying what you want in this and that situation.
Can you tell me, what do we need to do to increase the CT scans? You said there's 8 million out there. Do we go to the primary care physician, public education campaign? Where are you getting your referrals primarily?
You know, one of the only professional groups that came out against it, out and out against it, are the primary care specialists.
Yeah, incredible. Really?
They refused to embrace even any part of it, even think about it.
Do you know the rationale for that?
I have no idea.
Has to be
It boggles my mind. I think you just have to call people out on it when these decision points come up. I think number one, people have to come out and say this would not happen with any other cancer or any other evidence-based piece of medicine. I mean, to say that this trial isn't strong enough is the craziest thing I've ever heard in my life.
Where are you currently getting your referrals primarily?
They're by and large individuals and a few physicians that feel it's the right thing. I think that's the same thing. Yeah. And it's generally motivated individuals, found some reason for help, that they want to do this for their health. But it's been very, very hard. I mean, the hospitals, let's say it's been a fight with our hospital too. I mean, they're concerned about the reimbursement. And, they're concerned about, having enough scanners, and but that should be a problem if we don't have enough scanners.
I mean, my personal belief is it's about education, and it is about, as much as I hate to say this, policy, right? So when whomever the authority is says that this practice has to have X percentage of all of their patients get the flu vaccine every year, or else we're not going to reimburse you money, and you do the same thing for colonoscopies or mammograms, and then you insert lung screening in there, I think things change. And then not as much as I think we should penalize doctors. Obviously, I don't want to be penalized, but I think it is being held accountable to standards of care that are appropriate. And I think, one of the big holdups is if CMS isn't going to come out and say we approve this, then a lot of these policy changes we're not going to see occur. And so I think it is, using those bodies that you have that are lobbyists to lobby the people in government who can't seem to make any decisions lately. But lobbying them that change has to happen and making it happen, I think, is one of the first steps.
I think the analogy that Dr. Chris made earlier about the $450 dinner that he went to recently, I think people on the other end of the line are looking at the bill for 8 million people going out to a $450 dinner over the next 3 years.
Yeah.
But it's less expensive than
it's just, but it is crazy. I also would call out anybody who says they're a cancer center. If you had a way of cutting the mortality of the most deadly cancer by 20%, and you're not doing it, you should be ashamed of yourself. Particularly if you're taking federal money too. So I call them out.
Great. I just want to say one thing about stigma. Though no doctors or family or friends said anything to me, acquaintances, when they would say, I heard you had lung cancer, did you smoke? And at first I was very defensive and said, why, do you? Or, is that the only thing you can think of asking? And then I realized that if they were a smoker, they were afraid that they were going to get lung cancer. And if they weren't a smoker, they were like, I don't smoke. So it's just really education and awareness that we have to bring to everybody. Like I said, lung cancer doesn't discriminate. If you have lungs, you can get lung cancer. And if we can just let people know and we can whittle away at the stigma, I think it would be helpful for everybody.